Gemma, would you like to just sort of do the announcements?
This is a public meeting. We are live broadcasting the meeting via YouTube, and a recording will be available afterwards on the Council's YouTube channel. Please can I remind people that the speakers in the ceiling are sensitive and will pick up background noise, so please do try to keep this to a minimum. We are not expecting a fire drill this morning, so if the alarm does sound, please follow the officers out of the building and gather in the cathedral grounds. Please understand we've been seated board members as a priority at the table due to space in the room. However, if anybody at the back wishes to speak, please do come down to the allocated seat being pointed out now, and this will ensure you're better captured by the microphones and also the cameras.
Okay, thanks very much indeed, Gemma. And obviously, they're kind of normally it is packed seats around the table, but as we know at the moment, we don't have because of the logistics. So I think the first item is around the minutes. And are there any questions or about accuracy or anything that somebody needs to raise which is not on the agenda, which they needed to do so? I'm seeing nobody. Everybody happy to agree those? Thank you very much indeed. We've got apologies from absence from Councillor Lee Scott, Councillor Beverly Egan, Peter Davey, Councillor Maxine Sadsa, Paul Scott. Tom's here, and Davey, Ian's here as well. Sorry.
I am, yes.
And Tom Walker. Thank you very much indeed. And actions arising. Would normally read out the outdates and actions if required. Gemma, I don't know if you've got those. It says on there.
No, I'm not aware of any actions arising.
Okay, and we're all going to the other. Bringing those people come through. Also, I think that in terms of the actions arising, there are a couple of other things which, if I may, we'll revisit those and read those in the notes, because I know that not everybody's here, which may need to just pick those up. So we'll pick those up subsequently. Questions from the public? I don't think we have any this time. Thank you very much indeed. Okay, so if we can move on then to the Health Watch report. We've got Sam with us. Hello, Sam. Welcome. I think this is an incredibly important report, and as many of you know, this is actually very personal to me for personal reasons as well. And I'm very, very keen to see the work which has gone on around suicide prevention and understanding. So it's not just about prevention, but it's also about understanding the issues over the last few years now, Sam, isn't it? And I think actually absolute credit to the work that the team have done, and I know, and Jane also, because we're seeing some changes in the figures, but it is still a real challenge for Essex, those figures. So without more ado or stealing any more of your script, I'll pass over to Sam, but thank you very much indeed for the work.
Thank you, Ian. I have got a couple of slides, which I will talk to, but I'll try not to just read these on slides for you. The first thing to say is that I would love to have shared the full report with you today, but due to this having gone through more levels of governance than the 10-year plan, I don't have it with me today, and the last meeting was unfortunately postponed. So it will be hot off the press, hopefully, with you in the next week. The second thing to say is that the first iteration of this report was 187 pages long. There was an awful lot of lived experience in here, and people were very open and honest with their feedback. So there are going to be a series of continued case studies and insight that we'll be able to share in various formats. So for those of you that are unaware, the community asset mapping work is a tripartite piece of work between Community 360, CVS Tendring and Health Watch Essex. And we've been doing these pieces of work for the past 4 years, initially under the Live Well domains, and now focusing on particular areas. And this report focused on mental health and suicide prevention. So we look at the initial statistics and we focus in on two particular areas, one in Tendring, one in Colchester, but we had to kind of expand that slightly because there was such crossovers. People don't just neatly fit into one area. They use services, they work and they live in different areas. But Beer Church in Colchester and Shrub End were two areas of particular concern, as was Harwich and Great Bentley in Tendring. So move on to my first slide. One of the things we felt was really important with this was ensuring that we spoke to a range of professionals. And this was probably the biggest insight that I've found from reading that initial wave of work. One of the things that distressed me most was the impact that this is having on mental health professionals and wider healthcare professionals. So the daily challenge of being faced with people who are acutely unwell, who are talking about taking their own life, is a huge emotional toll on those individuals. And that's not just those people that work in mental health services, that's GP receptionists, that's PCN members, that's social prescribers who have not gone into a field of work thinking I want to be a mental health professional, but are dealing with these challenges on a day-to-day basis. And one of the key recommendations to come out of here is really looking at how we upskill, support and ensure there's access to high-level support for those individuals. Obviously, we work very closely with EBIT, but also staff across voluntary and community sector as well. If we move on to the next slide, there were some really high-risk groups involved in this. So the support that I put in place for my staff, as well as the staff in the other two organisations, was really key. We knew they'd be hearing distressing stories, and we made sure that there was that infrastructure in place to enable them to have safety calls, but also debriefs and professional escalation if needed. But we worked with some incredible charities and organisations who were really generous with their time and their stories. Just to give you a flavour of the kind of depth and breadth, we had places like Next Chapter, who very much support people with addiction. We did a lot of work with veterans, a community really impacted by suicidal ideation, and some of the organisations supporting them, like ICARP, which is Fishing for Veterans. There were some particular groups that were highlighted. Middle-aged men, we know statistically, are an outlier. And menopausal women as well was another area where there was increasing concern. But as you can see underneath some of those sort of groups that we were particularly worried about, there are fantastic organisations supporting them. So a big part of this report is making sure that people know the support that is out there already and know how to access it. So we'll just move on to my next slide. This isn't a particularly easy presentation to give. As you can imagine, there are some really sort of difficult stories, so do bear with me. But this quote, I just had nothing left because I'd carried so much for so long. I'm just going to let you sit with that for a minute because that's what people are facing. If we move on to the next slide. One of the things that we found throughout this report is nearly everybody had trauma. Whether they expressed that as trauma, whether that was known trauma, whether it was something that they had experienced support for, either trauma had led to their mental health or their mental health had led to trauma in their life. And often that was the starting point that then led to secondary addiction challenges around alcohol, around drugs, around inappropriate behaviour, gambling, vicious cycles of repetitive abusive relationships. There was this cyclic effect of one leading on to another, and patterns that became increasingly difficult to break. Move on to the next slide, please. So the reason that we do these pieces of work, the reasons that we dig into these communities and ask people to share their most vulnerable stories is so that we can put forward recommendations that as a group of professionals we can work on. And as much as I've said that this report isn't yet published, and I will share it with you as soon as it is, some of these recommendations are already having ripple effects in our community and actions are being taken against them. one of the things that came up really clearly was that we need more support for our neurodiverse patients and neurodiverse people. A lot of these people hadn't got a formal diagnosis but had real challenges. Some of the challenges leading to their mental health was difficulty in accessing a formal diagnosis. This has led us on to carry out some additional work around ADHD in particular. We've done a survey and that report will be published next month. But there's a lot of professionals I need to link in with before we do that, because there is a huge response coming out of this, impacted further by the changes in ADHD medication and prescribing, and the challenges that GPs are facing in supporting individuals with ADHD. We also, massive thanks to Essex Police, one of their staff came forward and recorded a podcast with us talking about the challenges of holding down an important job when your medication just gets taken away from you and you can't afford to access it anymore. So already we're looking at the secondary work that's coming out of this. Trauma-led approaches. We've been working with trauma for a while. Many of you have seen our trauma cards. Our trauma ambassadors are a fantastic group, and the art exhibitions that they have been hosting. From the success of that, we have been commissioned for a pilot study for young persons' trauma keyrings. So when somebody said young people with trauma, automatically everyone jumped to an app. Let's have a digital solution. And when we actually spoke to the young people, they said, I don't want an app. I don't want something on my phone. I don't want that. I want a keyring that looks just like a normal keyring. So if I've got it on my keys, nobody looks at it and says, oh, look at you with trauma. But I can use it and get it scanned if I'm in a place where I feel I want this person to know, I feel triggered, I need some help. So if you are working with anybody who's a young person who you feel would benefit from that, please let me know. And also, if you see one of those key rings, please scan the QR code. And if you want more training or support, come to us. There are a few organisations across Essex delivering really good trauma-led training, and EPUT is doing some fantastic work around trauma as well. So, please do link in. One of the things that comes out across the report from all of us, all of the three organisations finding, was about restrictions to accessing specialist mental health service. Some of the case studies are heartbreaking, and so I can't read them out to you now, but I encourage you to read them. And one of the things that people found really difficult was relaying that story, making themselves very vulnerable, and then having to repeat the whole thing to another professional or another organisation, and the emotional toll that was taking on them. And more often than not, that individual, that health professional, desperately wanted to help them, but they were outside of their remit. And that record, that story did not get transferred over to the next partner. Advocating for those experiencing menopause or those at-risk groups. There's been some fantastic work done across Essex in relation to menopause, and organisations like ECC, having menopause champions, and women's forums is fantastic, but there is more that needs to be done. Looking at our HR policies and looking at the support available for people experiencing menopausal symptoms is really important. We are starting our women's forum, building on the success of the men's forum, to help people feel that they've got somebody to talk to. And we're also carrying out research into women with multiple long-term conditions. Often the work that had been done had been very condition specific, but puberty, pregnancy, menopause impacted hugely on long-term conditions. We were treated for one or and actually that could be really confusing for somebody who has multiple long-term conditions and is getting different advice from two different specialists. Which one do you go with? So we're doing some research into that.
Sam, can I just ask you to... Sorry,
yes, I'm on my last slide, promise. Addressing limited access to services, particularly in Harwich. Harwich kept coming up as a challenge, especially with men in Harwich. Establishing multi-service, multidisciplinary mental health hubs so that people had that one-stop shop to accessing all the different types of support that they required, medication, talking therapies, as well as support for their physical health, and enhancing mental health support for staff across all statutory services, not just mental health professionals. So as I started at the very beginning, it's not just our mental health professionals that are having to hear really difficult stories about suicidal ideation and extreme mental health conditions. Thank you very much.
Sam, thank you very much indeed. And I would say that one of the things which this really highlights is it breaks some of those myths, some of those, oh, we know which group it is, oh, we know what the problem is, we know where the problem is. You know, I'm going to be pro for just a moment, just saying Great Bentley, we know that's, well, no, actually people wouldn't necessarily think that. The work that's going on is phenomenal, it is making a difference, but we know for Essex it's still a huge challenge. James, just arrived, welcome Jane, and I don't know if you wanted to add anything, because obviously you've also been doing a lot of work in this area. I don't know if you briefly wanted to add.
Yeah, thank you, Ian. Apologies, I was a few minutes late, so I'm glad I got here for the end of your presentation. I think that's a really rich research, if you like, that we can definitely use to influence the direction that we're going in. We know we're doing some good work. You know, I've always been clear that there's so much more that we need to be doing. And just to reassure the board, you're coming to our next Suicide Prevention Board meeting on the 1st of October. So I'm looking forward to seeing how we can translate some of that into what more we need to do and build that into our work programme.
Thank you. And I think that every time, you know, looking at, there is not a silver bullet. There is not. And the other thing is, it's not just about the people who are either have attempted to take their lives or have succeeded. It's actually the families, it's the people around, it's the impact on much wider, and of course on societal as well. And so it's just a massive impact on a much wider scale. Was there any comments? Sorry, Sarah.
Yeah, thank you, and thank you for that. I think one of the things I was going to say, which Jane has picked up, is that it's really important for us to join this up and make sure, because I think a lot of the things that are coming out of here are things that the conversations that are happening at the Suicide Prevention Board. I think there's something here about how do we make every contact count, because anybody could come across someone that's struggling with their mental health and well-being, and sometimes it's about having a conversation at the right time with the right person. I remember we had some conversations with head teachers, and we know that there's a big issue here with young people and mental health, and teachers have told us that they want to help young people trust them, but they're actually very nervous around mental health issues because they don't want to get it wrong, they don't want to make a mistake, and they want to support people in the best way. So I absolutely agree that it's not just about mental health professionals. I think in terms of training, because one of your recommendations was around training, we do offer training, but we really struggle to get people to take it, and maybe that's one of the roles of people around this table, to maybe make it a priority and try and encourage people to do some of that, because it prevents them getting stressed as well when they're having to deal with things that they're not used to dealing with on a day-to-day basis. I think there was something in the recommendations about pathways and making sure people knew where to go to get support and what was available. We do commission frontline, and one of the things that might be an option is to maybe look at how we get information onto there, because that's kept up to date, and we can signpost people potentially into one source of information, because our GPs are so busy. We know they haven't got very long and they can't remember everything, so there might be something there that can strengthen that. I understand that we've already got some mental health hubs, and tendering is an example of that. So I would put a plea in for building on what's there and learning from that, rather than maybe increasing other options, because I think we're all struggling to get to everywhere we need to do. And then just to say, I really think that the most important one there is around the dual diagnosis, and how do we get services to deal holistically with a set of issues and not just one issue at a time, because then we just get frustrated people who feel like we're not understanding, and it's just the way that the system is sometimes set up.
Sarah, thank you. I think that training issue, we've gone through with all our managers and all our counsellors, just so people recognise it and ask the secondary question. You can always say, how are you? Oh, I'm fine. No, how are you? And that's just the second time around. Just so many different examples. Paul, I had next.
Thank you for the report and some really powerful quotes and some really powerful evidence that you collected. I mean, there are sort of three things that sort of stood out for me. I think one is just how important that early prevention lens is for all of this, focusing on the ideation, not just on the deaths. Both matter, but I think it's really, really powerful to get us focusing in that way. Also, the thing that struck me was the impact of stigma. And how I think, in a sense, that's becoming a rising issue again, and also the compounding effect of access to smaller towns and transport being a factor there. Clearly, the gaps, the neurodiversity, the personality disorder, and dual diagnosis comes through very strongly. But I think again, and it's something, John, maybe to sort of just reflect into next week's session on the 24th, is the criticality of place and neighbourhood in all of this, and how we use our data to really identify those neighbourhoods that are maybe outliers in terms of higher levels of ideation being a really interesting part of that, and how at the same time we have the right discussions about allocating our resources proportionate to need. And that, I think, is going to be, again, a really important part of how we design neighbourhoods going forward, that we do actually allocate proportionate to need. Everywhere gets the basic, but we need to make sure that those that need more to actually level up and be equitable in the outcomes we're trying to achieve really does. There's one question. There's a reference around counselling and really mapping. And I mean, clearly the role of trusted local assets, the various community groups you referred to in the report and presentation. But what's our understanding of the range of voluntary and other types of counselling that is available across the patch? Do we have a map of that?
For North East Essex, there is a map in the report of what we were able to find whilst doing that research, but it is contained to just the North East Essex area.
I'll just pick up your point about also the early doors, the work that's going on. We've had it to the board before around the primary schools, around the 33 schools now that's there. Those are the sorts of things which we need to work out how I call it industrialise, grow it, how we make sure that it's not just North East Essex, so, but actually it is wide, and I still think that there's a lot we need to do there. Councillor Guglielmi came here having done something with the scrutiny and looking at it as well, and it's time and time again it's been proved to be so powerful. Tom.
Yes, so I think kind of building on what Paul set out, I think once we get the full report, I think it'd be really useful to kind of split, because I think that it feels like there's sort of two categories. There's some tactical things, isn't there, which it feels like we could probably be getting on with now in the immediate term, and so so I think it'd be good to work with you in terms of those, and then also what are sort of the longer term. So kind of we're going to need to change the way that we say commission service within Essex in order to better meet that need, and how do we work that through? And so there's more offer, Sam, once the full report comes out, it'd be really good to work that through with you and the team in terms of how we can build that into our planning for the next year and beyond.
Thank you.
And I think last one's Sarah.
Yes, Sam, I just wanted to say thank you for that, because it's really good, and I don't think looking forward to reading the report is quite the right terminology, but you know what I mean. I just wanted to say that in Malden we've been working in the suicide prevention space for some years now. Absolutely agree again with Sam with the issue around support for professionals, because my staff team are not mental health professionals. We had an absolutely wonderful suicide awareness event last week where we had hundreds of people come down and receive flowers and information, but my team were in tears because they had to keep taking a break because they were getting told personal stories about what was happening, and they were so busy preparing for the logistics of the event, they hadn't mentally prepared themselves for the event. So I think that's something really important. We've had some quite good success with the ZSA training, because we've adopted a slightly different approach in Malden, in that we haven't just given the link to people and say go ahead and do this training. We've created workshops where we present the training and then people sit through it together, and those have been really effective and very, very simple to do. So if anyone wants to adopt that approach, then please come and talk to my team, because we're very happy to do that. What we've struggled with is we've tried to find training that includes safety plans for people, so that we're talking to people who may or may not be at risk of suicide ideation and thinking about how they can protect themselves, like they can develop their own personal resilience. And we found that training, and we've been able to put that in, particularly with the farming community, because of the Malden district being rural. That's been our focus. But we have found that safety training is, one, very important, but two, quite difficult to find, and three, quite expensive. So there's kind of a note there that if we can find funding to roll that out across the county, then that gives a layer of personal resilience to people, which is important in this space. And just another note that from a community perspective, we've approached this in looking at protective factors. We've completely taken and said, we're not mental health professionals, we can't help with the counselling, we can't help with the access to mental health services, we can't do that, but what we can do is wrap around the support within the community and try to be protective so that people don't move into crisis. And that's the approach that we've taken, and it's worked quite well. So I just wanted to kind of feed that in to say that there kind of like is another side of that, to say what is the community doing to make sure people know who people are, they know they've got someone to talk to, they feel connected, and they've got personal resilience built in.
Sarah, thank you very much indeed. Sam, thank you very much, and also Jane, for that. And I think that this is an item which we could have spent an hour and a half talking about, or the whole meeting talking about, and there's lots of other things which we want to talk about, we've got comments from the police and the discussions we could have. But I'm going to wrap this up because my very poor chairmanship in my very first item I've actually overrun. So apologies, John, handing back to you and giving you a challenge of having overrun. But I do think it's such an important item that we plan to hear some of the very heartrending stories and the work that's going on. And actually, it's really because there is changes going on across the county ICBs, across local government. And how do we, when we do this reset, how do we make sure these things are not lost? Because actually, this is the important thing. And without that, I'm going to just throw the rugby ball back to you, John.
Let's overrun.
And well caught.
Let's overrun, my dear friend, and completely demolish the timetable. Good morning again, everybody. Normal service is resumed. Thank you for that, Sam. Coincidentally, on the same topic, I chair now the Children's Partnership Board, one of the statutory boards, and we received a report last week from a range of voluntary youth organisations reporting being overwhelmed with mental health. I'm already sharing it with ICB chairs. Could we circulate it, please, Alison, to the whole board? Yeah. And can we please, to those who consider future agendas, consider how we can give you the time you clearly want on this topic. We are well behind time, but I still believe it very courteous for everybody to know who everyone else is when they speak. So can we very quickly go around the room? John Spence, Chair.
Ian Davison, Chief Executive, Tendering District Council and Vice Chair.
Gemma Bint, Democratic Services Officer.
Jane Gardner, Deputy Police, Fire and Crime Commissioner.
Nick Presmag, Executive Director, Adult Social Care.
Councillor Graham Butland, Political Representative of the Mid-Essex Alliance.
Nicole Wood, Chief Executive, Essex County Council.
Sarah Troop, Director at Moore District CVS, representing the voluntary sector.
Tom Abel, Chief Exec at Mid and South Essex ICB.
Paul Burstow, Chair of Hertfordshire West Essex ICB and Chair Designate for Essex.
Mike Thorne, Chair of Mid and South Essex ICB.
Wahid Khan, Essex Police Chief Superintendent.
Tom Lafferty, Chief Executive of PAH, and apologies, I need to go at 10:45 today, please, John.
Will Pope, Chair of Suffolk North East Essex ICB.
Sam Glover, CEO, Healthwatch Essex.
Sarah Muckle, Director of Wellbeing, Public Health and Communities.
Alison Bielitska, Senior Strategy Advisor. And then you've got people on the outside, John.
On the outside, please.
So start with Emma, you go first.
Emma Hayward, Cabinet Assistant for Councillor Spence.
Oh, you made it, well done.
Gavin Wilkinson, Partnerships Officer, Essex County Council.
Shaman Jolata, Head of Partnerships and Equalities at the county.
Maura McGrath, Director of Strategic Commissioning and Integration, Adult Social Care.
Daisy Kingsford, Essex Child and Family Wellbeing Service.
Andrew Graham, Learning Disability Health Equalities Commissioner, Essex County Council.
Paul Herbert, Head of Integration and Partnerships at ECC.
Michael Farrell, Integration and Partnership Lead with ECC.
Maria Chiara Di Cesare, Director, Institute of Public Health and Wellbeing, University of Essex.
Sierra Nelft.
Gina Palisi, Partnerships Portfolio Holder for Tendring District Council.
Deborah Stewart Angus, Chair of the Essex Adult Safeguarding Board.
Michaela Jury, Safeguarding Adult Board Manager.
Chris Carpenter, Qualities and Partnerships Advisor.
Andrew Lowen, Equalities and Partnerships Advisor.
Nathan Rowland, Health and Wellbeing Board Secretariat.
Sean Cook, Senior Analyst, Public Health Intelligence.
Nifty Patel, Public Health, Essex County Council.
David Title, GP and Clinical Lead for Care Close to Home West Essex.
Lucy Whiteman, Chief Executive of Community Interest Company called Provide and the Group Chief Nurse.
Morning everyone, Chris Martin, Commissioner Director, Children's Services, Essex County Council.
Connie Howells, West Essex Post Director.
Mark Carbaron, Policy Officer, Essex Police Fire and Crime Commissioner.
There you've got Richard in the corner who's running the...
Sorry, yeah. Richard Buttress, Democratic Services.
Okay.
And we don't have anyone online, John.
Thank you all very much. One's always made very conscious of the responsibility to make sure so much high-value time is used to best effect. I would say to people up the back, if you want to come down to be better heard, please do so. By going now straight to Deborah Stewart-Angus, Chair of the Independent Essex Safeguarding Adult Board. I do want to stress that Deborah's rightly shared concerns with me before that we do not stress enough the independence, and I want to make sure, Deborah, you and the board have the so you're going to give us an update, Deborah?
I am. Thank you, John.
John, just while Deborah's getting ready, you've got two more people have joined. You've got Laura Taylor-Green and Ian Tompkins.
Greetings, and to all who have survived the train journeys, well done. Deborah?
Thank you. Is it okay for the presentation to go up? So thank you for asking us to come back today. This presentation is basically an update on how we've deployed the first 18 months of our business plan for the Safeguarding Adults Board for Essex. Next slide, please. So what I thought would be helpful to look at would be, first of all, a quick overview of the plan to remind ourselves of what we were trying to achieve, the strategic goals, any adaptations and corrections we've had to make, which we passed forward, the deliverables that we've completed within the last 18 months, progress on the objectives that we've set, some stakeholder feedback, and the current challenges and next steps that we face, hopefully with some solutions. Next slide, please. So we're going to have a quick brief on the overview of the business plan. Next slide, please. So you may remember that we had three main goals for this business plan, which were prevention, learning and quality. And these were the original goals set out in the strategy that we brought here in 2024. So it's a 3-year strategy, and these were the key focus areas that we felt were still relevant from the previous 2 years, but with different objectives. Next slide, please. Any adaptations that have been needed to have been made to the business plan in relation to forward planning or achievables have all been dealt with, and necessary adaptations have been made with corrections, and where possible and able to do so, we've put that into the following year or a different part of the year, but basically everything has been covered. Next slide, please. So quickly, if we can now look at what we've actually looked at delivering. Next slide, please. So objective 1 around prevention. The key deliverables that we were looking at were around equality, diversity and inclusion, regional cross-working, strengthened engagement and increased accessibility to safeguarding information for members of the public. The actions that we set ourselves, sorry, I just need to swap glasses, was to try and engage self-impaired groups, work more closely with the voluntary sector and community leaders and faith groups, and share the knowledge of our safeguarding challenges faced by these communities, particularly with an equality and diversity inclusion lens. We aimed to identify the gaps and increase accessibility to help and information around safeguarding, particularly for those who are at risk with care and support needs, and increase cross-working and strengthen our campaign messages. So next slide, please. This is the results of how we did on that particular goal. So quite a lot of achievements in this area. First thing, one of the first things we did was we appointed a specialist project officer who we've received very positive outcomes about their role and their impact that's made. And that specialist project officer was able to cross-work with Children's Board in relation to a whole family approach and in relation to transitional safeguarding, where children are coming out from children's social care possibly moving to adult social care, possibly not. But that transitional period being a key risk area for a lot of young people. The specialist project officer has focused on a lot of work in that space and there's been a positive impact. Particularly from adult social care, who put in an awful lot of time and effort around what's called the mate space. So that's one thing we did. The second thing was patient safety assurance. We have focused a lot of time working with EPUT in seeking assurance around patient safety, their patient safety planning, their forward plans, their analytics and their metrics. And we have worked really closely with them and they have been committed. Particularly, obviously, we're also working with the Lampard inquiry at the moment, where we supply information that's necessary when requested, and we get support through ECC for that. We have sought assurance also from adult social care in relation to safeguarding practices and processes, and they have presented to us on that and shared their information with the board. And we have also sought assurance around accommodation seekers. We focused largely initially on Wethersfield, which is, you may know, the old RAF site, where we had been in receipt of reports from a variety of sources around a lack of safety for the people who were living there. And we decided that as a board it would be useful to contact the Home Office and ask them to come in and comment on the information that we had been in receipt of. We did that. It was positive. In saying that, we felt as a board that we needed more detail and more clarity on Home Office practices and procedures in relation to engaging, particularly with the adult social care teams in Essex and the board ourselves. So that worked out quite well. It took a few times. They came in total, I think, every quarter for about a year, and they're still coming this year too. So now, obviously, we're moving more over to the issues that are around the bell. We've sought assurance on what their plans are. They're due to come back at the next meeting for our board in October, where we've asked for different people to come in from them, various directors, to talk to us about plans around if there's going to be a transition of anybody from that particular hotel. But obviously there's the case going on at the moment, so that may be delayed. But also the issue in relation to Wethersfield, because just at the point really where we started to feel that safety was being assured, obviously things seem to have changed somewhat. And we're looking at the potential plan for the Home Office to increase their figures there to 1,000 men. So we are having some concerns about that. Hence why I've invited a chap called Ryan Outtread, who's the Director of Accommodation Seekers and Asylum Services at the Home Office, to the next board. We have established contact with seldom heard groups via our Committee on Prevention and Awareness, and that's gone out to consultation, and that's shown some success. And we've also reviewed all of the cross-region Southend, Essex and Thurrock multi-agency policy and procedures for safeguarding adults. We carried out a big campaign on National Safeguarding Awareness Week, which obviously is at the point of the year around November, and we've had a 12% increase in our take-up for our newsletters, etc. We do joint work with Jane and with Suicide Prevention Board and Children's, as I've just explained. We've deployed a new website to increase accessibility and information availability. And we have worked very hard, as have the ICBs, and thanks to them in this room, for aligning our strategies for safeguarding across the piece. I know now we're going to be in a different position again. However, it shouldn't be
if you like, not acknowledged the amount of work that went into that alignment and to ensure that we dovetailed with our strategies for adult safeguarding. So thank you to the ICBs that were former. We decided we wanted to create a directory of services to enable further engagement with the public, and we have engaged something called Frontline, and that's now planned for our website for it to be linked there. And I've mentioned the Lampard inquiry, and we've also, in the midst of all of that particular objective, managed a 200% increase in our safeguarding adult reviews, which has been huge and made a big impact on us as a board and on the board management team. So that's what we achieved in relation to Objective 1. Could I have the next slide, please?
Could I just mention, Deborah, if you keep the same pace on each objective, we'll struggle a bit, I'm afraid.
Okay, I'll try and be quicker. Is that helpful? Next slide, please, was, I've done that, Objective 2. So Objective 2 was learning. We wanted to deliver learning as soon as possible from SARS, with increased effectiveness in the SAR process, SAR modelling, and our quality outcomes in relation to EDI. So our actions were, as you can see, making safeguarding personal, integral to all safeguarding referrals and IMRs. They're the independent management reports we receive for a safeguarding adult review, which is a statutory requirement. Early learning shared quickly. Revised quality standards, we've revised those for our processes. Alternative SAR methodologies have been developed and are in place. And we wanted to aim at getting more appropriate referrals than we were, because a lot of the referrals we were getting was about 30% inappropriate. Training standards have also been put into place. Next slide, please. What did we do? We achieved the methodology review. We did that. We did a quality review, and we've trained 2,811 multi-agency staff. We've introduced professional curiosity training, legal literacy. We've aligned with Bournemouth University safeguarding competencies in all the training we've delivered, and we have introduced new e-learning that we've developed ourselves, and lunch and learn sessions for some of the ICBs. Particularly, we focused on Mental Capacity Act, fluctuating capacity, self-neglect, coercion and control, and hopefully we see an impact from the safeguarding portal as well that was instituted by Adult Social Care. Next slide, please. In relation to quality, these were the actions we set. So improving the quality of SARS, practice improvement to be embedded from the SARS, lived experience informing our improvement, appropriate referrals, biannual safeguarding and self-assessment audit. All partners took part in that, and a peer challenge. Next slide, please. What did we achieve? We completed, all statutory partners completed the self-assessment, which was brilliant. We have regular safeguarding adult data metrics and analysis and reporting in place quarterly. All statutory partners attended all learning events held for practice, and the peer challenge event was very well attended. Work's ongoing in relation to how we correlate partner safeguarding adult data with the police and with the NHS. Next slide, please. So we've had positive stakeholder feedback. I believe there's a continued importance in our shared dialogue. We've maintained trusted relationships, and relationships are strong. We got very positive CQC feedback about the strength of relationships on our board, and hopefully that's by some degree of strong leadership. Next slide, please. Next steps. The current challenges that we face, we had received some partner contributions less than required, lower than expected, which has affected our budget. The increase in the SAR referrals overall has made a big impact as well. We predicted there would be an increase, but we've actually received a greater increase than we predicted. So that has increased the impact on us budget-wise. We've got a potential loss of a post, but we've been able to resolve that at the last minute. We've been looking at ways to resolve that. My biggest fear, if you like, about the impact on the budget in relation to challenge is sustainable lawful compliance. It's my job to ensure that we are lawfully compliant. If we don't receive the contributions that we need to move forward, then compliance obviously is threatened. And another challenge, obviously, will be system integration if we go through the LGR role. Some solutions. I think there needs to be recognition of the ongoing achievements that we've clearly made and continue to make with a very small budget and a very small team, and the legal status that we have, and ultimately parity with the Children's Board. We do not have parity with the Children's Board in relation to our funding from partners, and that is something that we are going to seriously look at in relation to an options appraisal that we're currently developing. Ultimately, a sustainable approach to this board is a legal requirement, and it's a legal requirement to enable partners to deliver their adult safeguarding responsibilities. The board is the partners, it's not the board team. So that's the challenges we face, or some of them, and thank you for listening.
Deborah, thanks, Brew, because I want to make sure we have time for discussion. So 2 questions from me, if I may. Under the prevention piece, you talked about the creation of the new website with the ICB help to improve accessibility. We were hearing earlier about the difficulty of getting people actually to engage. So have you been able to measure success so far on that? And secondly, you just slipped in there something I didn't know. What's the scale of the imbalance between the children's and adults safeguarding funding?
To answer the first question, John, I think we've had, in relation to the website, I think it's 33,000 followers at the moment on the website. So we're seeing a big impact with that.
Good.
And we're seeing a big change. We did have a lot of positive results from the former website, but this is more intuitive and accessible. So we have seen the figures go up massively in relation to contacts and when people hit on the site and make comments and things which have been positive. We haven't had anything awful on it. So that's good news. In relation to your second question, that gap needs to be measured. And that's exactly what we're proposing in an options appraisal to partners that we haven't presented yet because we're just completing it, to look at what those gaps are and see how maybe they could be considered to be filled if that's a possibility by partners.
Thanks very much, Deborah. Further questions for Deborah or comments?
Paul
Burstow.
Just very quickly, just picking up on that sort of surge in the referrals, just to sort of understand it. I mean, self-neglect is an issue when it comes to it, but it would be interesting to sort of hear a little bit about to what extent the quality of the referrals themselves are a driver of the numbers.
Yeah, I can respond to that. So we did have some concern when we saw the first part of a surge, which was actually last year. And so we looked at the appropriateness of what we were receiving, and we did realise at that point that we did have, as I said, about 30% that we felt were inappropriate. So we've addressed that, or we thought we'd addressed it, and we put together a training programme, an e-learning training programme that we basically insist that if any professional is going to make a safeguarding adult review referral, which is a massive commitment for the board, as you can imagine, they're exceedingly costly, then they have to have completed this training first in relation to the appropriateness of the referral that they are making. We insist on that now, and that's gone into place. However, we did genuinely think that may reduce the referrals. It hasn't. People have taken more interest, and it seems to have actually increased the referrals that we're getting. So perhaps we've drawn attention to it more so. I can't really account for the increase other than to say that it does match the increase that is being seen in adult social care in relation to their referrals as well. So we're seeing you draw a graph, 2 lines both going in the same direction. It correlates, and we get more referrals from some areas of Essex than we do from others.
And seamlessly, Nick President wants to come in.
Thank you. I mean, I was just going to see what Deborah's already said, which we're seeing a general trend, which is an increasing trend. And the principal drivers are professional referral, ambulance service and hospital referrals. The provider referrals sit outside of that. We've got a lot of providers who de-risk themselves simply by raising a safeguard rather than dealing with the issue. So we know what's driving it. I don't think we've quite worked out exactly how to turn the tide on it, but we know what's driving it. Second thing I'd say, just in relation to SARS, you'd have seen there was a spike. I think that's in relation to three things. We had a backlog during COVID.
Yes, we did.
We have a safeguarding chair who's very curious and uses discretion in certain areas, which I think is welcome. And of course, we have the Lampard inquiry. So we are very vigilant in making sure that everything that is looked at should be looked at. And thematically, the issues that we deal with as a system are multidisciplinary working, neglect, powers of entry, for which there is some national movement on that. And then it's interesting because social workers are generally against changing powers. Directors like me are generally for changing powers. That's because I get the prevention of future death notice.
Thank you, Ian.
I was just saying is how do we make sure that we don't lose this with the changes?
Yes, exactly.
And I think that's that's something which, whether that be for the ICBs, whether that be for the local governments, and I think that's a piece of work we do need to do, regardless of what any future configurations are.
I would be grateful for that.
We'll come back to ICB and LGR later on the agenda. Yeah. Okay. Deborah, anybody else? Sorry.
No.
Done. No. Thanks, Deborah. That's excellent. Thank you. Very informative. Thanks very much for all your work. It's one of these days when we've got quite a few of these serious issues. Leader, the learning disabilities fatality rate and life expectancy. Will Herbert, I think you're speaking to this.
I think it's Andrew Graham for this one.
Andrew, is it? Okay.
So thank you for having me here today to speak about the Southend Essex and Thurrock Leader Annual Report 2024-25. LEADER, or the Learning from Lives and Deaths programme, reviews the life and death of people with a learning disability and or autistic people. It's now an over 18 programme, and it has been for the last 18 months. This report itself provides an update on the achievements of the 3 integrated care boards and Southend, Essex and Thurrock local authorities, as well as the Transforming Care partnerships. With regards to the reporting period itself, we saw a record high number of notifications. We had 127 notifications of people who had unfortunately passed away. The average age in death raised very slightly to 59.56 this year, and within the papers and the notes we've shown a graph to show that we lost some of our oldest population during COVID, so the average age is recovering, but not at a great speed at the moment. So we do want to see more improvement from that over time. Also, against our key performance indicators, which we report into NHS England, that's related to how we complete reviews within time limits. Our performance improved to 88% this reporting period in comparison to 65% for last reporting period. NHS England sets a reporting target of 100%, but it's important to note that across England, completions within 6 months was 38%, and across the east of England, it was 35% for the same period. So we're still outperforming the national and regional average. Unfortunately, respiratory illness such as pneumonia and aspirational pneumonia remains the greatest direct cause of death for people with a learning disability in Southend, Essex and Thurrock. Some of you may have seen a couple of weeks ago the new national report came out for deaths in 2023, and that had cancer as its #1 cause of death. So we're continuing the trend of respiratory conditions being the #1 cause of death, not just in Southend, Essex and Thurrock, but in the east of England region as a whole.
Can I just ask, I've done a lot of voluntary work with learning disabilities. There was a higher propensity to smoke. Is that still a factor?
So we had a look for some data on that. So the ONS for the general population in Essex said that the percentage of current smokers is 12.2% and ex-smokers is 24.1%. We couldn't find any local specific data, but using leader data for this year, we had eight smokers, or 5.9% of our completed reviews that we reviewed, and 8 former smokers, and that was also 5.9%.
That's lower.
So it's half. Yeah, it's hard.
Okay, thank you. Sorry, if anybody was distracted there by Ian Davison playing with my leg, a suspicion I had just angled his device cable around my shin. Sorry, Anne.
Slightly different.
So the report highlights obviously a lot of progress. We established South End Essex and Thurrock leader champions. We've got champions representation from all the local authorities and integrated care boards. Well, we have representatives from the safeguarding boards, and we're also working with more than one representative in organisations. So, for example, in Essex County Council, we have representatives from some social work teams, we have representatives from commissioning, we have representatives that support the safeguarding internally as well. So we have a lot of really good links, and they're really helping to not only increase our knowledge, but also our recommendations per review, delivery of those, and same with our health colleagues. It's been a wide range. There's been some really great work across the footprint. I know the provider quality and innovation team has started learning from leader sessions where they use some of the learning from the leader reviews and help providers understand where they can make improvements. They've also been looped into every recommendation we send to a provider within the Essex County Council footprint. We know that our health colleagues through the quality teams are embedding our recommendations, and there's also representatives from the ICBs that are running time to learn sessions where they're trying to use some of the information from LEADER as an impetus to basically make a positive impact, which we're really thankful for them for. And also the learning disability liaison nurses in the hospitals continue to do an amazing job. And there's so much positive practice that we've captured. When I came last year in the 23-24 period, 50% of our leader reviews had captured positive practice. For this reporting period, 24-25, 75% of leader reviews had positive practice noted. And again, that multidisciplinary teams were one of those, but again, learning disability liaison nurses really key in hospitals. We've come with 5 recommendations as part of the report. They're focused around end-of-life planning and ageing well. I know the board previously has expressed that too many people are dying in hospital and not having the choice to make plans for the end of their life, so that's something we want to continue pushing. Cancer screening, because that links to kind of the national trend of increasing cancers that we're seeing. Respiratory health risk factors. So we're looking to do a work together with organisations to create a checklist or use existing ones that are there, because there's so much that comes down to respiratory health risk factors like postural health, dentistry, along with swallow and other factors. We want to support the work of the 3 public health teams across the local authorities that have their healthy weight work going on. I know Essex has its 10-year healthy weight strategy, and I believe there's a speaker today to talk about that. And then also, which I think is the most pivotal point, is to continue to push forward the learning disability annual health checks, but really the health action plans. Because the health action plans are really the opportunity to change the trajectory of people's lives, maintain their health or reduce deterioration, and they are something that needs to be moved forward and every year to review the previous plan to see if they can make positive changes for individuals. Because that's one of the learning points we pick up in LEADER, is that things are picked up and not always.
I would really hope that the new creation of the community diagnostic centres would help with that. And increasingly, where we've got these mobile health check units going into workplaces, which I think are absolutely sensational good, really. So, Andrew, that's terrific, thank you. Is there anything more you need from us other than a continuation of the points you've just made, your points 1 to 5?
I think it's just to continue to be our critical friends and highlight things. So in the report this year, we captured a section on self-neglect because it was brought up in last year's report. So if people want to see certain things that aren't in the report already, please let us know and we'll capture it in our summaries, because we have the LEADER platform that we use to capture the information the NHS want, but locally we also capture initial data so that we can grow our report and grow the learning we can take from our report.
Excellent. Thank you very much, Andrew. Questions or comments? And I know none of us would be happy to see continuing an average age of death with a 5 in front of it. But it will always take time to move this on.
Moira.
Moira?
I think the point about aspiration pneumonia is absolutely preventable cause of death, and the sort of nutrition, feeding, posture being absolutely critical. And some of that is quite complex about how we're wrapping around support around individuals. So that feels like a really key area to focus on. Something we talked about in one of our disability meetings.
Yeah, absolutely.
Thank you. Anybody else? Andrew, thanks so much for coming back with your annual report. You must always make sure we know if there are things that we're not doing that can to help you in this space. Okay.
Thank you.
Thank you. Now, Will, is it really you this time to talk about the Better Care Fund?
Yeah, I believe it is. So we've got the quarter one. Yeah, we've got the quarter one BCF report. There's 3 metrics in there that I just want to draw attention to. The first is emergency admissions, which we are on target for, achieving a rate of just over 1,500 per 100,000 population against a target of 1,600. On the discharge metric, I think it's important to highlight the way this is captured and reported back nationally has changed. They're developing a national database for this. Based on the information in there, we are on track. However, there are gaps in the data, and that's a national issue they're working on. There'll be an opportunity to review our targets set for this metric at Q2 once that's been addressed and we have a more complete picture. But for us, I say we are on target for the target we set earlier in the year, achieving an average delay where there are delays of 6 days against a target of 7, and 90% being discharged on their discharge ready date. On residential care, we've moved from reporting on the SALT return to client level data, which gives a more complete picture, but this does change how the metric's captured, and it now includes CHC changes and capital drops, which has led to an increase.
I need to know what CHC is.
So that's continuing healthcare. So that's the move from it being funded by health to local authority funded. And that has changed our performance on that metric. We're slightly off target on this one. So we set a target of 425 per 100,000, which was quite a stretching target anyway, and would put us amongst the best in the region. And actually, with the changes that have occurred, we are now the best performing in the region on this metric. So I think it's important to highlight that, despite being off target, how well our performance compares to other regions or other authorities in the region and our comparator authorities. I think that's testament to a lot of the projects funded through the BCF, so things like care technology, which is now supporting 15,000 people to remain in their homes, and the increase in support to carers as well through increasing direct payments. So I think some real positives there, despite being off target on that one. And just to set the context a little bit more on that, the worst performing amongst our comparators is 781 per 100,000, so a real difference to the Essex performance there. Other than that, it was just to highlight our expenditure is also on track. So we're spent 24% of the planned expenditure this year, noting that we tend to see increases in expenditure over winter as well. So by the end of the year, that will be fully utilised, the fund. That's everything to report on.
Thank you, Will. I don't know if any of our ICB colleagues want to make any comment. It's a joint venture, sorry?
Sorry, Laura.
Oh, Laura, hello.
Hello, apologies for being late.
You were one of many affected. Well done for getting here, Laura.
Thank you. I'd just like to say I think that the work that we do with the Essex County Council team is really proving of great benefit to our local residents. I think that the Essex-wide schemes that all residents can benefit from are really valuable, but I'd just like to highlight that the delegation of a local budget has really allowed us to make progress, to make sure that we work with local stakeholders, to make sure we put in the right schemes for local residents. So I'd just like to think, just for the board to recognise how important that place-based decision-making around the Better Care Fund really is for our residents.
Thank you, Laura. Nick Presley.
Thank you, Chair. Just so I'm sure colleagues in the NHS have picked up on this, but there is a national review of the Better Care Fund. One of the things it's going to do is going to make it more challenging to disperse the money locally across a number of schemes. Because what the government has said is it wants to get the spend into quite well-defined categories. So there will be the opportunity to respond on that. It might be helpful if the board takes that opportunity. I shall let the board know when the opportunity arises.
Well said. Anybody else? So we are asked to note the Better Care Fund report for Q1, and you've heard the actions that are being undertaken and the work underway. I just thank all parties for the way they work together on this. I'll just thank Laura. Can I just thank everybody who's managing to get here in the end, despite the challenges on transport. Of course, it was so much easier when it was just dry and hot. You didn't have any consideration bigger trains, roads getting flooded. We come to an important item. I'm going to have a bit of a joke with my great friend Ben Hughes. Are you now online? Ben Hughes?
Yes.
Best all got here, Ben. Okay.
Well, he's had a really bad morning. Be kind to him.
I've been on various trains since about 7:45 this morning, and could get no further than Colchester, as there is a tree blocking a train.
Yes, well, yeah. I'm teasing you because the rest have made it, mate.
Oh, I know. Yeah, but
we each other well enough to have that joke. Now, the area of complex need, the demands that these people have on the system, whether in justice, whether in health, whether in social care, all the other facilities, remind us of just what an important cohort this is. And I'm looking forward. Ben and others have been doing a remarkable job, actually. Sarah, I'll let you introduce the item and then hand over.
Yeah, thank you. So we started off talking about what was happening within prison from an adult social care point of view, and thought it was a really good opportunity to have a more broader discussion, not just about what we do within the prison, but also about how we support ex-offenders and think about that wider approach to preventing reoffending. So it's a joint act with Michael and with Ben on this one, so I don't know which one of you is going to start.
Shall I go first and get it out the way? So I'm taking it as read that everybody has studied the paper that we presented. It presents the breadth and depth of the work that is commissioned and led on by public health through the health and justice lens. And the things I'd wanted to highlight were the targeted support that we're applying, as John mentioned, through the complex needs agenda, applying a positive persistence model to addressing and engaging with those who are engaged at with the criminal justice system, both as victims and as perpetrators, and the line there is often blurred. And the Changing Futures agenda was a pilot that we were successful in bidding for, that gave us an additional £5.5 million over the last 5 years to actually engage with these individuals, and the outcomes were so positive that we have actually now extended beyond the end of that pilot and have commissioned a complex needs service to cover the whole of Essex County Council's area for the next 7 to 9 years to engage with this cohort. I think one of the other areas that I wanted to highlight within the report that you are seeing is the housing support and employment support that we provide to these individuals. Obviously looking at the needs of these people, either looking at prevention and preventing them going into prison in the first place, or engaging with them to prevent reoffending and to support them into more positive life outcomes for them. We have seen significant positive moves with regard to specialist housing support in relation to drug and alcohol users and those with complex needs, but also the individual placement and support schemes that we fund for drug and alcohol users has been extended to meet the needs of those with complex needs and offenders. And we're seeing significant positive outcomes with regard to people coming out of prison with plans and actions in place to address their employment and housing needs. I'd also point you to the issue in relation to the low representations to this service. Generally, the reoffending rates nationally are around about 30 to 36%. The representation rate to the complex needs service, which takes its referrals through the criminal justice system, representation within 12 months of being successfully discharged is down at about between 4 and 6%. So we can see that actually applying this model is reducing the number of people that are coming back round the cycle of criminal justice engagement. Key concerns, however, it's a concern and both an opportunity. As we are all aware, NHS England is disappearing shortly, and many of the responsibilities around health and justice sit with NHS England, and there is significant uncertainty around where the future of commissioning will lie in relation to this cohort. We are working closely with the Office of Health Improvement and Disparities at the Department of Health to look at retaking responsibility around prison drug and alcohol services. But I think there is an opportunity here for the ICB and other colleagues to work with us to explore opportunities to take more local control over commissioning services in both the prison and also police custody and the community. It would be useful to find out whether people have the appetite to that. We are currently working with NHS England to kickstart the pre-existing Health and Justice Commissioning Group, working with Adult Social Care and previously some Alliance leads to look at how we can bring this group back into existence. And to highlight the sort of individual positive stories around this, I've got two very brief case studies that I just wanted to share with you. One is an individual, a 35-year-old man who came to the UK from Kosovo as a child and was identified with significant PTSD due to his experiences of the war as a child. He was on remand in HMP Chelmsford when we first engaged with him, out with alcohol issues, cannabis issues, and ketamine issues, all used for self-medicating and coping. The prison link from the Phoenix Futures team that we commissioned, the Complex Needs Service, engaged with him in prison and on release to work with him on his benefits, his drug and alcohol treatment needs, his mental health support and accommodation and employment, and looked at weekly face-to-face contact once he was released from Chelmsford Prison. He now has applied for his PIP. He's back into mental health support through ePut. He's also being supported by the Mental Health and Wellbeing Service in Adult Social Care. He's been supported to attend the job centre and now has a council property and has a job as a customer service assistant with a company in Chelmsford. All of this has been facilitated by the work that the Phoenix Futures Complex Needs Service has done to coordinate a team around him and to bring him and to ensure services are delivering concurrent support to him to ensure that we are not missing any of his needs. The other case study is a 19-year-old young man who was identified as or diagnosed with autism and ADHD, who was self-medicating on significant cannabis. He was engaged when he was cautioned by the police for cannabis possession. He's known to have significant gang involvement, and his peer support networks are not necessarily the most positive. And he lived in a very small flat with his mother. His neurodiverse needs were assessed, and he completed a neurodiversity passport that has been developed by Phoenix Futures, so he no longer needs to explain every time he engages with professionals what his situation is. He's now working and engaged with social inclusion activities across where he lives. He's engaged with the counselling service and has applied for suitable accommodation and is working well with services for the first time in his, so say, adult life. And these are two of many, many case studies that I can provide that we've collected over the last 5 years of the Complex Needs Service, where we can see by applying this model and looking at the breadth of need that these people present with, we can actually see really positive outcomes. Thank you.
Thank you, Ben. Who's coming next? Sorry?
Ian. Did you want to...
You get me down the front here.
If there's any questions, or I'm happy to continue.
Any point. You can hear in this the commitment Ben has to the service, and he brings his personal lived experience as having been a prison officer to really have the means to convene in this world. But I'd also want to pick out the Essex Recovery Foundation, which Ben very much drove, working with those who have dependencies and addictions and doing terrific jobs there. And by the way, Ben, I really ought to be going along to them at some point. Questions for Ben. Have you been educating Southend and Thurrock into this activity, Ben?
Southend and Thurrock are engaged and linked into the work we do, and obviously we are working closely with them to prepare for whatever comes next under local government reform. And we work closely and align our drug and alcohol services. The Essex Recovery Foundation has also now been asked by both Southend and Thurrock to work on building their lived experience engagement more efficiently.
Excellent, thank you. Who's next?
Well, I was going to say, Michael's in the room. Do you have any more that you wanted to add?
Yes, I just wanted to highlight quickly a piece of work that we've done with Chelmsford Prison as part of this, just to kind of show the importance of relationships and partnership working, and the joint working agreement that we now have in place between Adult Social Care and Chelmsford Prison. Just to give a bit of context, first of all, the prison's got a capacity of about 700 at any one time, and within adult social care in the last 3 years we've had over 100 referrals for social care support. The number of that's increasing and becoming more complex due to the nature of the population, complexities with ageing. And between adult social care and Chelmsford Prison, we didn't feel that we had very good working relationships in place to facilitate that and to ensure that we're supporting people as well as we can. So we agreed to get together and form a joint working agreement, which we now have in place. The basis of this is to set out what adult social care and Chelmsford Prison can and cannot do under our respective legislation, but also to go a bit into the finer detail in terms of how our different teams and services operate, and what we should be expecting from each other in terms of things like timescales, being able to access the prison and prisoners, safeguarding, all sorts of different areas. We have this in place. It's been very positively received by both adult social care and Chelmsford Prison in terms of setting out how we'll be working going forward, and also how we'll be managing referrals. One thing that I think is very interesting to note as part of this work is when we really started getting into the detail of things, despite there not being very good working relationships between both organisations, when we were working through the different sections of the agreement, there was agreement on probably about 99% of the different areas. So we really felt that we were already working in the same sort of way in what we would expect from each other. I just don't think we were that good at articulating it and building those relationships, which are so key in such an area. We're very keen, though, that we don't want to see this as just a standalone piece of work between adult social care and Chelmsford Prison. So we've been looking at other opportunities where we can branch this out. For instance, there's the Housing Protocol Group, which adult social care are now a part of, which kind of brings together all the different district councils in Essex to kind of look at how we're supporting prisoners with housing. We're also looking at delivering some sort of equipment guidance for Chelmsford Prison. That was one of their main issues that they had, was around the provision of equipment and care technology in the siting and how we manage that. We're also working with Children's and Families colleagues, which we've spoken to previously about this agreement, and what this means for young adults and people within transition services that are part of the prison and how we could be supporting them. But also, as Ben has highlighted, we've done some engagement through the Mid Alliance and with partners locally to see what we could be doing more collectively. But also there is the potential for the Health and Justice Commissioning Group to look at this wider across Essex to make sure that we're supporting prisoners as best we can.
Okay, thank you. Nicole?
So it's partly been answered, but I mean, a fantastic report, and the outcome is incredible, isn't it? A representation of 6%. But it was really about that scaling. It's, you know, it's obviously such an investor save, isn't it, in terms of £1. So I suppose my kind of question is, what do you need from us to get that scaled, the profile right? You know, where is MOJ in this? Might be one for you. I don't know who.
Michael or Ben, who'd like to have a go at answering that?
I'll come into this first. I think from where I've been doing a lot of work in this, with adult social care and other partners, there's a lot of services that public health are providing, but in terms of our general conversations through the Alliance and with other partners, Chelmsford Prison is a large site, but also it seems to be seldom heard in conversations we have. And so I think my ask really is that we keep the conversation going as much as we can, and to make sure people are supported as best we can through the prison. I think it's a no-brainer that if we support people as best we can when they come out, we're less likely to see reoffending and getting people back into society, which can only have good outcomes.
Thank you. Ian Davidson.
Thank you. A couple of words. Just echoing what Nicole just said, that, 6%, that means 94% of people are not representing in a year. That's phenomenal. A couple of things, though, is that one is that I went and visited Chelmsford Prison and have done some work on a couple of occasions going there. And one of the myths which I do think we need to kind of bust a bit is about saying to people is that people are coming into Essex. No, for the most part, people coming out of Chelmsford Prison are going back home.
Yep.
They're going back to the areas from which they come from. And therefore, people who are saying, oh, there's been given tickets to come to, fill in the dots. No, actually, they're going back to home. So I think there is a bit of home recognition of that one. And the second thing is more a question, is you talk in the report around local housing authorities, but of course, of the 12 districts, not all have housing. Some of them are not housing authorities, and actually some of them have an arm's length, or some of them don't have any housing at all. We do, sorry, I'll be parochial and tendering, we do, and so we can actively take part because we have housing, but others don't, and you say all evolved. So how does that get managed? And the other part is the homelessness, obviously, which comes out of it, which then leads itself to the potential for reoffending if there's not proactive responses to the homelessness issues.
Can I just ask, a district council will still be a housing authority even though it's delegated off or seated off all its functions, wouldn't it?
So in terms of actually having the housing provision, some are do it at an arm's length, and then some actually have completely outsourced it.
Yeah, but they've outsourced.
It's no longer their housing, they're no longer their holdings.
Yes,
they don't have those responsibilities.
They're still the responsible body.
Yes, but they don't. They won't necessarily have the draw on it.
Yeah, but that doesn't stop them creating it.
So.
Sorry. I don't know if Michael or Ben want to come back on that, but I've got two more, so if I can pick them up. Jane Gardner.
Thank you, Chair. So Ben knows I'm a big fan of the work that he does. As the Chair of the Reducing Reoffending Board, I'm an even bigger fan now, given the statistics that we've heard. I think this is a real example of working across a system. And Ben is integral in both the Reducing Reoffending Board and also the Essex Criminal Justice Board. I welcome the comment from Nicole about how do we scale this up. It's all about money. And Ben, you asked a very specific question about what's our appetite for this. You know my appetite, so let's continue that dialogue. I too am having conversations with NHS England, and I hope it's helpful, but I'm encouraging them to give all the money to Essex, as only I would, because I just think this is an incredible example of where you can do something different across the system, but have the absolute impacts that you want to see for the recipient of the service. So thank you for what you're doing.
Thank you. Chris Martin.
Thank you, Chair. It's been touched upon, but just to kind of reinforce that point, in terms of upscaling, very obvious area would be and we've been talking to Ben and colleagues about this, but for the work that Ben's been leading to start reaching down into young people, because many of the issues that Ben has mentioned are relevant to young people before they offend. So in terms of bang for buck and value for money, I would obviously be encouraging, and we've had these conversations, as I say, with Ben, to start into young people before they offend, because I think the support that the service provides would be relevant to people at an early help episode and not just as a consequence of offending behaviour.
Thank you, Chris. Tom Abel.
I think it's to Jane's point, and also kind of Ben referenced it. So with the wider changes going on to the NHS, it's obviously the plan for all of the things that NHS England currently commissioned to be delegated back down to ICBs. And so I think there will be an opportunity to think about how do we shape that as we move forward, and what can that mean locally in Essex. And so it's a bit early days in terms of exactly how that's going to look. But I think if we can get the commissioning group restood up, Ben, and I know the team are keen to do it in the ICB, we can start to think about how we might want to influence that shift back to ICBs of those responsibilities.
Thank you, Tom. Anybody else?
Ben wanted to come back.
I'll come back to the answer. Anybody before I go back to the presenters? No, Ben?
Yeah, thank you, John, and thank you for the questions. With regard to expansion and lobbying MOJ, Nicole, any weight that we can bring to bear as a whole system would be really welcomed. We are putting pressure on it from the public health lens through OHID, but any further pressure would be useful. Tom, in relation to the shift to ICBs, the significant concern we have is that the shift to ICBs of the NHS Health and Justice function is being planned, and it is very early days, to go to Norfolk and Suffolk, and the money will not be ring-fenced or protected as a health and justice budget, which could see significant threat to the investment available. So it would be useful possibly to think about how we get Essex's share of the pie to Essex. With regard to housing, we work with the local housing authorities and the housing providers. And actually, one of our most successful schemes is working with Colchester Borough Homes on a scheme called Hosts in Colchester, which provides specialist supported accommodation for those with complex needs, which we fund from our complex needs budget. And we work really well with Colchester Borough Homes around that. I think that's all the question. And the other thing we need to remember is, whilst Chelmsford Prison is in Essex, an awful lot of people are released from prisons outside of the region, and we do an awful lot of work with Prison Link into prisons outside of Essex. And we also have to remember we do not have a women's estate in Essex. So all of the women in prison that are released to Essex are released from outside of Essex. And this is a significant area of work because women are poorly represented in the criminal justice system and often forgotten about.
The way in which your presentation brought the room alight, Ben, is testimony to the quality of the work and the merits we can see in it. We do have the incoming chair of the Norfolk and Suffolk ICB here, so I'm sure he will be making sure that we do not suffer Will Pope financially.
Noted, John.
Seriously, somebody said earlier, we must not lose this. We must not lose this. And I say to you, Nicole, we need to be thinking very carefully within the County Council how we can best let our partners know, and the people who will be the future leaders of the county and its unitaries, all the things that they don't know go on. And these are things they don't know about. So I offer that thought. Ben, many thanks, and Michael, thank you for that very stimulating presentation. We are now on to receiving the pharmaceutical needs assessment. I'm not quite sure who's speaking to this.
It'll be Dick. Do you want to come down?
Would you like to come down, Mr. Patel?
No, she.
Oh, right, sorry.
John's deputy.
Hello, deputy. Sorry. Didn't know who it was. Right, so this is a responsibility of the Health and Wellbeing Board to receive and approve the pharmaceutical needs assessment. Do you want to speak briefly to the key points?
Thank you. And I've got Sean Cook with me, who's one of our analysts in the public health team. As you've just said, the pharmaceutical needs assessment is a statutory responsibility of the Health and Wellbeing Board. So I'm here to present it and ask for the Health and Wellbeing Board to approve it, because we need to publish our next health and P&A by October 2025, according to the NHS Pharmaceutical and Local Pharmaceutical Services Regulations 2013 and amended further on. The P&A is replacing the last one, which was undertaken in 2022, and it is a responsibility for us to update our P&A every 3 years, a statutory responsibility. It is developed by a steering group, which is made up of partners around Essex. So we have representation from the 3 ICBs, we have representation from the local medical committee, the local pharmaceutical committee, and obviously the public health team and the analysts here at ECC. We also have Health Watch on the board as well. The P&A will inform interested parties such as local authorities, pharmaceutical contractors, GPs, and local health systems of their provision across the area and help them to plan and develop services for the population of Essex.
Thank you. I have received no representations on this time, as I did on the last 2 occasions, so I have no reason to do anything other than recommend approval. Does anybody have any questions or concerns?
Yes, there's Mike Thorne.
Michael?
Yeah, just a couple of things really. I mean, I confess I haven't read the act you've just quoted from start to finish, and my knowledge of this is kind of what comes here every time it needs to. I mean, our pharmaceutical needs now are different, aren't they? Because we've got pharmacies doing a lot more for us than they used to. So in specifying our needs, for example, is it possible to say you can only open somewhere new on our patch if you really do the following list of things that go beyond the mere supply of drugs? So, you know, do you have facility to offer health checks? Do you, will you help us in all these different ways? Will you definitely be offering the, whatever the current list of low-level conditions that we would expect? Can that be put into it, and do we put that into it? If so, because otherwise we don't really want them, do we? Because they're only doing half the job as it's now specified. That's question one, and then I'll come on to the other one.
Okay. Do you want to answer?
Yes, in case I forget what the question was. The unfortunate thing is that we undertake the pharmaceutical needs assessment for the area, but we are not responsible for market entry, which is how new pharmacies would open. So that is still a responsibility of NHS England. So they will take our pharmaceutical needs assessment into consideration when there is an application to open a pharmacy or amend hours or have a dispensing doctor open or close, or a distance selling pharmacy, which is an internet pharmacy. But the pharmaceutical needs assessment just provides the facts, and NHS England actually make the decision.
Okay, thank you. So
I'll just say, Michael, my experience from the last two, the reason that one got blocked was because it was deemed that there would not be enough business for the two within 400 metres of each other to be sustainable. And that was what caused the major issue. So it feels to me as if the guidelines on which this is produced may be out of date. Actually.
And that's my
NHS England issue.
So question two is, in the list of people that were involved in this, I may have been having a little nap, but you didn't mention a hospital.
No.
What you see, so I stood in a queue in Boots in Whittam yesterday behind a lady who couldn't get her cancer medication because it was on a hospital prescription. And it had come to the local Boots. I hope this doesn't identify an individual, but it wasn't. She couldn't take the medicine because the local pharmacy wasn't licensed to do that, and she could, however, take it as a private prescription. And she looked enthusiastic because she was weighing up the cost of getting back to Basildon, obviously, and that was going to be £168. So, funnily enough, she declined. Now, again, we shouldn't be having that sort of stuff. And if we had a hospital involved in that design, wouldn't it help? Or again, are you telling me I should just go back to the ranch that I'm in charge of for another nine days or something and sort it out there?
That is unfortunate because hospitals are not part of the local pharmaceutical provision. This is purely a community-based provision that the pharmaceutical assessment looks at. Hospitals are excluded. NHS prescriptions, as you rightly say, that are written in hospital can be dispensed privately out in the community. And that's when we realise the cost of drugs, because if you and I were to go into a pharmacy, we would just pay £10 per item. But when you're paying privately, the cost is significant. But unfortunately, it's not within my gift.
But we do, Mike, have a specific project going on that issue.
Okay.
Because there is the ability for hospitals to effectively send a prescription, as your GP would, electronically to your local pharmacy. So we've got a pilot going on initially with frailty services, but if that works, we can then look to extend it to other specialties because, yeah, it doesn't make any sense at all.
Thank you, Chairman. I've come here to learn what's going on at home.
Alberto?
Yeah, just a couple of sort of, I guess, reflections and sort of question in there as well. Obviously, this assessment, although it's not the decision-making tool, it's the tool that helps the decision maker. So it does determine market entry to a significant point. I mean, given this is basically saying there are no gaps, again, I think that means that some of the other actors who are involved in supporting this process, ICBs and others, will need to be focusing even more on the shift to improvement and what's actually being delivered and whether the offer that is available is equitable and what access looks like. So I think that strikes me as being an area that it would be interesting to sort of shift the focus onto. In terms of monitoring, because obviously this is done every 3 years, but things change. Given there's a sort of delivery services and distance selling pharmacies, being watchful for someone leaving the market and it's opening a gap in access. How is that done and what's the sort of monitoring arrangements?
We have to write a supplementary statement to the pharmaceutical needs assessment. We tend to do that on a regular basis every 3 to 6 months with the steering group. But what we have decided this time is that the steering group will meet virtually, and if there is a decision to make, then we will make that onto the P&A. If the supplementary statements add up to something significant, then the P&A would have to be reviewed and undertaken as a full exercise again.
It's been very educational for more than you, Mike, I can assure you. Any other points? Sarah, can I just are we content to approve? Subject to all the caveats. It does feel that, Sarah, somebody needs to be going back to pick up the points with those who formulate both the content of the questions, the design of the questionnaire, and those who then take part in the assessment.
Yes, we can do that. I think all of the points raised are points we raise a lot because it doesn't feel like we get the most out of this process, and it often feels quite bureaucratic in that it is about the way that NHS England want to use it rather than it being useful for us locally. But we will feed it back.
Thank you very much. Thank you. And we were going to have a break here, but we're now 15-20 minutes behind schedule. I'm guessing you'd rather finish nearer time than be 20 minutes late. So if I could continue, but if anybody needs to use the facilities, just please try and slip out as quietly as you can in this room. The ability for creaking is the sort of thing I can remember putting in place outside my daughter's teenage bedroom. Story. We come on to connect. Jonathan Douglasson is here. Sorry?
I'm just done.
Very good. Come on down, Jonathan. You have all received the paper. I'm going to ask all presenters, please, to recognise the paper as read. Will, you are prodding me.
It's Jonathan and it's Kevin Garrett as well.
Kevin, good morning. Jonathan and Kevin, fire away.
Good morning, Chair. Good morning, Health and Wellbeing Board. We've been allocated 10 minutes for this item, so I will be brief. I'm conscious that you're already running over. The item we're speaking about is the Connect to Work programme, which I will skip the background and context of. It's the content of the paper, which is in the agenda pack. We'll cover off the detail of the Connect to Work programme. Just as a summary, however, this is a programme that we have been provided with almost £30 million of funding from the Department for Work and Pensions to deliver over the next 4.5 years to the period of March 2030, which allows us to deliver in total almost 8,000 people with disabilities or other barriers to employment, including health barriers, back into work across the Greater Essex region. The content of the update for the board this morning, and I believe, Chair, it may be useful in a couple of months' time to come back for a further interrogation of the programme in detail, actually. It's not often that people invite themselves back for scrutiny. However, I think it may be useful in this circumstance, is to give you an update to confirm that as in line with the planned timetable, the Connect to Work programme went live in Greater Essex on the 8th of August this year. In that time frame, we've had over 120 applications for support. We've been able to onboard over 12 people onto the programme, which is in line with the targets that we had for the August period. And I'm very pleased to confirm that as of 9 o'clock this morning, we've now had 2 participants who have been supported into work, both of them through our provider ECL, who is delivering our SEQF element of this, a specialist in employment, one of the specialist employment support frameworks that we're using. And both of them have secured employment, one as an apprentice hair technician, as one as a motor mechanic. So I promise you I won't give you an update on every employee that we receive going forward. However, I thought it would be worth noting, Chair, that we've been successful in securing 2 people work placements within the first 4 weeks of the programme going live. We've got good demand for the programme, so we have this is a programme that's a Greater Essex programme, will long term be one of the mayoral competencies in the MCCA, but at the moment is operating across the Greater Essex footprint. We are receiving significant demand within the Essex area, and we're receiving referrals from both our health partners and our voluntary and community sector, as well as self-referrals from our residents who are interested. We're also obviously delivering across the Thurrock and Southend footprint, this being the Greater Essex programme, and we're starting to receive referrals from those footprints as well. The positive news continues. We've now got a full team that is onboarded, and the programme is starting now to ramp up all the way through till January 2026, when we will have the final commission provider who will be onboarded, delivering a consortium approach as the prime provider, leading a consortium of voluntary and community sector organisations to support people with the wider barriers to work outside of the core mental and physical health work that we focused on in the first part of the programme launch. This is all in line with the timetable that we previously outlined in verbal updates and in written updates to the board members, and we're very pleased to report that the forward demand for the programme is looking strong. Our next steps will be to submit our first claim for this programme, which will be going into Department for Work and Pensions in October for the first of the quarterly claims, and we'll be happy to report back. And we plan to establish, and as my colleague Kevin will cover off in a second, a scrutiny board for the Connect to Work programme, which will meet first in October to cover off the detail of the programme and provide oversight of all of the local authorities as well as health partners. And I'll hand over to Kevin just to cover that, if that's okay.
Thank you, and good morning. The reference that Jonathan has made to a delivery board, you will see that in one of the slides that is closely linked to the deprivation one. There is a miniature version of a framework around Essex Working, because this is connected to the bigger policy piece around Get Britain Working and potentially further investment, whether that's through an MCA route or other routes to be decided at this point. But the ask of that particular plan, and I've referenced it in the document, is that there is a framework that enables Connect to Work and other programmes to operate in a consistent and cohesive manner. So that is an early sight of that. We continue to work on some of the detail. Very interestingly in the commentary, because we have recently had a movement of the skills part of the jigsaw, if you like, to DWP as opposed to sitting with DFE, but that plan always involved employers, reference bodies and skills, and of course the ICB alongside an MCA and a health and wellbeing board or boards. Depends on how that plays out. We have also tried to accommodate new programmes, emergent programmes and important pieces of work in that, but not being prescriptive at this stage, but also enabled a format where unitary authorities, as part of local government reform in the long term, can also operate into that space. So if you like, some of the investment that we know little about at this stage, except for ministerial announcements, are Pathways to Work, which has been brought forward from 2028 to the beginning of next year. That is, on the face of it, from what the headline, a bigger investment in supported employment than we currently have through Connect to Work. So I think part of this work is about us readinessing ourselves for what that might look like across the next 4 to 5 years. I think the important point to raise in the detail of this programme is that there is a criteria and suitability, I won't say challenge, but we may have many people reaching the threshold for support but not actually being suitable for the programme. It's predicated on a particular model, most of it, called individual placement and support of supported employment, and that takes an approach about place and train and start people in work at pace. So the impact and emphasis on that is very much that people are coming into the programme that we are enabling as the AB in a state of readiness to work. They're willing and they're keen to work, and they have the basic components in place. So I was keen that people understood that.
So what do you do when they're not?
So within our triage function, we have, Jonathan, do you want to explain?
Yeah, so absolutely, Chair. So we have a triage function. The answer to this is no wrong front door. So we have triage officers that will assess the suitability and eligibility of the programme. We have also recruited an employment and careers advisor that can, for people who aren't suitable for Connect to Work, can refer back into existing adult social care or health-based programmes that exist within the county council. For example, they may have more severe or more acute impairments that require additional level of support through our commission programmes within the county council, or actually that there is an alternative requirement for health and for skills or employment support, that they'll go back into my skills team. So the answer is no wrong front door is the answer to that.
As long as they don't get dropped.
No, absolutely. If people have taken time to reach out, we won't drop them.
I would just say, apologies, I shouldn't be saying this from the chair, but I would have been very disappointed if we hadn't made early progress. We have been so committed for the last decade to ensuring that all people are enabled to work wherever possible. The health benefits to the individual, the life quality benefits to the individual of all ages from having meaningful engagement is absolutely central to the mission of my children's services teams, the adult social care teams, our public health teams. And we mustn't just let a programme overwhelm what is an underlying movement that's got to transcend however long that programme happens to be funded. That's the danger. The programme stops being funded and we leave it behind. Chris Martin knows the commitments that we have. This has to start way back. There are so many young people now being diagnosed with conditions, neurodiversity, learning disabilities, special education needs, whatever. You need to start right at the beginning. The adolescents are being developed for independence and living full lives rather than being deemed to be only fit for some sort of sub-quality life. All the work that Sarah's committed to, and I've heard Paul talk about it already around areas of deprivation. All of these pieces mustn't just become a programme that lasts as long as that programme lasts, all right? And I would just ask you always to put the very important work you're doing, which I fully support, in that context, okay? Is that all right?
Of course, Chair, no problem.
Right, in any way undermining what you're doing.
No,
absolutely. Recognise it's bigger. I'm sorry. Jonathan and Kevin, other questions for Jonathan and Kevin, other points?
Ian and Laura.
Ian Davidson and then Laura.
John, I absolutely endorse what you just said, and I think that's so important. And I just want to add that you mentioned sort of a number of areas from Essex County Council. I would say that also in terms of the district councils as well, that is very strong. Yeah. And if I can just give you a couple of things which actually have been hugely successful. In fact, we've got one in about a week's time, is our jobs fair.
Yes, I know.
And that literally has sort of 20, 30, 40 or more people getting jobs each time or more, and also leading to apprenticeships, etc. So hugely important. And going back to John's point is how linking which are ongoing in to making sure that it doesn't become a programme, because it can link to other things. And it seems look at Family Solutions, the way at Family Solutions, it started out as a programme and now it's ingrained into all of our working and the support there, so, which is really important. And the last thing is also... I just can't count, John. I'm only an accountant, don't worry. And the last thing is around our reverse jobs fairs and the way in which we've looked at thinking differently and innovatively in terms of bringing that in. So again, making sure that it does become ingrained across our working.
Yeah. And I would just say, guys, if the programme tries to report all these initiatives as having come out of the programme, you will not win friends.
No, of course not, no.
Laura?
Thank you, Chair. I've got 2 opportunities that I'd like to just encourage you to consider, and then 2 questions. So in Suffolk and North East Essex, we're about to sign off our health and work strategy. There's been a huge amount of work that's been really excellently led by Helen Bowles, and she's done some fantastic work. So I think she'd be really encouraging of this. I know she's been engaged with you, but not losing that as an opportunity. And then, of course, the neighbourhood pilots that are in North East Essex and in West Essex. So really considering how we link in this programme will be really important for those people we'll be working with. My 2 questions, one relates to Ian's, so really understanding how this programme is embedded in the economic regen and future growth strategies that are held in the districts. I think that's something, given the priority areas, I'd like to really to understand going forwards. And then finally, your point that this programme started from August 2025, but your governance structure looks future-proof for May 2025. So I'm a little unsure as to how the governance going forward is going to take place. Thank you.
I'll bring in Ian Tom. Are there any more? I'm just getting really short of time now. Ian Tompkins, and you know, there are brilliant examples, Laura, from all over Essex. Ian, I don't know if you want to list some more from West, but...
Yeah, so, I mean, obviously, this has got to link in closely with, importantly, education and further education. It's got to link in with the local skills improvement plan. In West Essex and in Harlow in particular, we're also established now a growth board for Harlow at district level, which workforce, as you rightly say, is so important. And I think importantly of all is that we need to involve employers. I know we are, but you just cannot keep forgetting that, particularly in terms of, for example, the NHS, where today our experience, we've had different bits of the NHS competing with each other at job fairs and so on. It's got to join up together.
Okay.
We do that with our West Essex Health and Care Partnership, which includes this.
Do you want to answer any of the points? But I think it'll be a very clear message.
Yeah, no, that's fine. I think so. All of those points are well made. I think, Chair, it would be useful to unpack some of those wider issues because they are contingent within the governance work that we plan for the sort of wider Get Essex Works Get Essex Working initiative that we've been tasked to deliver by Department for Work and Pensions. Connect to Work is just one programme, as you and colleagues in the room have identified a myriad of other supporting employment and employment work that's ongoing within the districts, within the healthcare sector, within local government, within Essex. So we've got a challenge to join those pieces up, and I think, and we've got a separate kind of governance regime that helps with that. Your point, Laura, around the governance being future-proof for May 2026 onwards, I think that's it's a good point. We've established it with a view that we understand what the future looks like immediately. We'll move to implement on the basis of the current structures that we have within local government, effectively there being an empty chair available for a mayoral combined authority representative when that is established in shadow form or in form of delivery going forward. I'm not paid enough, unfortunately, to second guess the establishment process for that particular programme. And then yes, I'm very happy to work with districts and colleagues in districts on their economic strategies. Jack from my team has worked with Helen very closely on the health and work strategy and commend the work that has been done in North Essex on that. It's coming together quite well. So yes, I think I've answered all of the points succinctly, Chair, if I can.
Thank you, Jonathan, and very best wishes for this. Look forward to staying joined up.
Of course, yes, absolutely.
Thank you, Jonathan. Thank you, Kevin. I'm sorry. Why are you muttering?
I was clearing my throat.
Oh, right. We're coming now on to a double act. Debated by Adrian Godwin and Jason Fergus. This item really should have been headed Healthy Living or Healthy Lives, or even, to use an old brand, Live Well. But Sarah, you're introducing briefly. The purpose is for us to be really understanding the work that is underway on the prevention agenda with the public health function. Sarah?
Yeah, I think John's introduced it well. We're trying to bring together two really important programmes. They do overlap. They are important elements of living well or living healthy lifestyles, and we're going to assume that the paper's been read and just pull out some key things that we want to highlight with you as board members.
We're 15 minutes behind, gentlemen, so make sure we use the best time. If we use all the time, so be it, but let's make sure it's used to best effect, okay?
Thank you very much. So I'm Adrian Coggins, Head of Wellbeing and Public Health, and Head of Healthy Weight, and my colleague.
Hi, Jason Fergus from Essex. Good morning, everyone.
Thank you. Could we have the first slide up, please? Thank you. Say again? I wasn't sent them. You weren't sent the slides? No, not for this one. We did send the slides. Okay.
They're the ones that were published with the agenda?
Yes.
Okay, I can pull them.
I guess most people have read them or got things.
Yeah, that's fine.
Can we just get on?
Okay. What we've got in the slides, so while you're finding the slides, if you can put them up, great, but I would just kind of talk to them a bit more generally. So we've got the two things we're talking about here are the Essex Healthy Weight Strategy, and which I lead on, and the Active Essex Fit for the Future strategy, which Jason leads on. And what we are not doing is treating those two things as separate. So what we're exploring is where is the common ground between those two things that we can usefully work on. And the common ground, I think the best descriptor for that is that we need to create the right conditions for people to be able to be physically active and to adopt a healthy weight and adopt healthy eating. So those are, that's the main thing that we're going to talk about, is how we kind of create those conditions. What we haven't done is just uncritically said, let's combine all of our work programs together. We thought very carefully around where are the particular things on which we can kind of work together, recognising what are some of the biggest determinants of the things we're trying to change. So within our healthy weight strategy, we have three key outcomes. A healthy weight environment in Essex, making healthy lifestyle behaviours the easy choice, and making sure that more people with excess weight are effectively supported to be a healthy weight. They are not all equally weighted in terms of their ability to determine the outcome of healthy weight or being physically active. So environmental conditions are absolutely critical. And what do I mean by environment? Well, that includes the physical environment, the cultural environment, the kind of socio-economic environment. And those environmental factors are common to both physical activity and to healthy weight. So we're trying to look at how we can best join up on those particular things. Jason, I'm sticking to the slides. I don't know if you want to say anything specific about other aspects of the healthy weight strategy, or I can talk a little bit about the connectivity. What do you want to do?
Yeah, no, I'll come in. Thanks, Adrian. And I think critically, I think as certainly as Sarah's just described, the kind of codependencies between actually what we're doing around the work and physical activity and healthy weight are so interconnected. And I think what we're presenting here this morning is actually how the connectivity of what Adrian and I are both doing together absolutely creates those conditions. And when we talk about things like physical activity, healthy eating, reducing stress, limiting alcohol, they're all connected to driving that healthy communities, that healthy weight opportunity. So what Adrian and I are really keen to demonstrate that actually something we've learned from our journey on the local delivery pilot was actually what are some of the key components that make a healthy community, be that social connection, be that physical literacy, the infrastructure, role modelling, open space, community safety. All of those things are interconnected, and we need to collectively as a public health team work together to really drive those together. So what we're presenting to you is an opportunity that I've been fortunate enough for the work I've been doing with Sport England, that Essex was awarded one of the local delivery pilots nearly 7-8 years ago now. And within that space, it really led us to take that opportunity and create some space, which we never normally have, to understand what are some of the conditions that we need to create in order to drive the change that we want to do. And what's been really fortunate for us is to be able to share that learning absolutely across the system, and particularly with the healthy weight piece, but also colleagues in this room that actually let's describe and understand what we mean by those conditions. So one of the first things that we obviously want to focus on is actually how we trying to influence the system. So actually how we position and learn with the system to be able to land some of the opportunities that we're landing. And certainly the healthy weight strategy identifies some of those opportunities, but also our place partnerships. Now we've got 6 places that we're working with in some detail across Greater Essex, and that really allows us to learn actually how do we hardwire not just physical activity, but actually how do we hire healthy communities, because that's absolutely the agenda that we're trying to do here. And obviously, as Adrian has absolutely described, that appetite for change is really critical. That's what we're trying to do. I think what's really been really quite exciting is the importance of creating a shared vision, actually, and that kind of shared vision, a really good example, actually, is in the north of the county, actually, where there's a healthy weight programme, actually, which has been co-designed by system partners in the North East, and on the likes of the public health team, Active Essex, and obviously Adrian's healthy weight team are coming together to try and shape in place, actually, how do we find that solution. So I think what we're wanting to really make the point, this is not siloed working. If we're going to be succeeding in what we're trying to do, we have to get a collaborative system approach to really working together and sharing resources, actually. And so it's not actually my resource, Sport England resource, or Asian resource, public health, physical activity resource. It's actually how do we pull those resources together the best opportunity for the people that we're trying to make a difference in their lives. Clearly for us, and recognising tackling activities is always a challenge. We've seen our latest active life data, where probably we've seen the best physical activity data ever, but actually we still have this challenge, which Adrian and I have both agreed that actually there is a need to tackle inequalities. There still are groups that we are not touching and getting to, where we need to ensure that we can make that difference. So there is some work to do. We do need the work of the help of this room to actually help us to make sure that we're reaching the parts that we absolutely need to make a difference on as well.
So you can flip through to slide 10, where we're talking about culture evaluating and making data and evidence-driven decisions. Again, this is a really common thing which Jason and I are tight on. We've learnt a lot in terms of the evaluation of the healthy weight strategy from the local delivery pilot. And I think the place-based approach and developing a common place-based approach is something which is, again, something Jason and I are tight on, because we need to be. What we can't have is lots of different approaches to a place-based approach in the same place. There's a real need to kind of join that up. So in terms of evaluation, so the local delivery pilot for Active Essex, I mean, that is the evaluation there is ongoing. We are at an earlier stage. We launched the healthy weight strategy last May. We have just commissioned our phase 1 evaluation. And in a nutshell, there are 2 key questions that we want to answer. And when I say we, that is everybody in this room, plus every other Essex partner who has a role to play in supporting the healthy weight agenda. So those 2 questions are, how do we know that we're doing the right things to achieve the outcome of reduced excess weight in Essex? And how well are they working? That's it. Those are the 2 key questions. Underneath that, there is a whole load of very complex methodology. I won't talk about causal inference theory or directed acyclic graphs, but there's a whole load of really complex stuff, and we're working with some of the world's best academics on how we look at what are the real drivers of this in Essex. So what you've got on the screen there are some of the kind of sub-questions of those 2 main questions that I looked at. So what works for whom, where, when and why? I think the point around current activity and future activity, that's absolutely critical. If we just carry on as we are and aggregate that up, why would we expect to be any more successful? That's a really key point. So what we're looking at is looking at the current activity. We need to validate some of that current activity. We also need to challenge it. It's very important never to kind of dampen anybody's enthusiasm, but we need to make sure that we are going in the right direction. But is there future activity which we're not doing, which we need to do, which is more likely to land the outcome that we're aiming for? And those are very much around the environmental determinants, and that's why we're working so closely with Jason on how we look at creating those environmental conditions. Next slide, please. So I think the ask of the Health and Wellbeing Board is to help us with the evaluation, and that basically means the kind of senior people in this room. Can you please, when we come to ask you, which will be in the not too distant future, sponsor the need for evaluation? We need to create a better evaluation culture in Essex than we've currently got. The Essex LDP has done a fantastic job of starting that, but we need to make an evaluation culture much more systemic. It's not enough just to do activity with public money. We need to make sure we're doing the right thing, so that's really critical. And I guess there's an ask of you and your staff to respond specifically to things like surveys, interviews, group discussions. We need to have a very important understanding of the system. We're not just looking at the projects that are currently happening, and are they working? So John mentioned earlier about the connect to work. There is kind of an overall ethos. There's an overall culture that we want to drive, which is beyond any individual programme. Exactly the same applies to what we are trying to do here. So we need to understand not just the projects that are happening, the programmes in which those projects sit, but also we need to understand the Essex system and change the Essex system. So when the ask comes in, if you can please support it and comply, that will be very much appreciated. So I think we're on to the last slide now, which is a bit of a joint ask, which is how can we, all of us, as a collective Health and Wellbeing Board, continue to create the conditions for healthy communities. And I'm really keen to see if there are any particular areas of creating the conditions where you think collectively we need to do more on. Thank you.
Thank you, Adrian. While people just take a second to think about the answer to the second question, I think on the evaluation piece, I'm not quite sure what our support looks like, Adrian. If you're asking us to give you support, does that mean that you want us to go out with surveys to people, or do you want Ian to engage with our district councils? I'm not quite clear what your ask was on evaluation.
So I think it's to be, for this board and your respective staff, to be reactive to the asks that we as an evaluation team will make of you. There will be asks of surveys, there will be some challenges to current practice to say, are we doing the right thing? So I think it's just to be reactive to those specific asks as they come in. The key point is to validate the need for evaluation, just that basic concept. That's something that we need to get better at doing. That's really, really important.
Ian Davidson.
Can I make an ask back then of that? Because I think that we around this table are not the sole leaders of the whole of the Essex public sector. We represent different areas. Yeah. So actually formulating something concise in the form of an email, which can put us a message, we can then use to go back to those which we are representing out. So we understand exactly what you're asking. And if I'm really honest, I'm not 100% sure still.
I'm sure.
That would be really helpful, because then I can send it to the leaders and chief executives of the councils for Essex. Our colleagues here at Health can send it to their representative organisations, etc., etc. But I'm not 100% sure that I do understand. So actually capturing that in something which we can send of ease and saying this is what's coming, this is what's advanced. Yeah. My second question would be, if I may, John, the second question would be, is what work have you done? So in terms of, for example, the work Jason's done has been phenomenal, has been fantastic. The impact, which doesn't necessarily come through on those figures, on the difference it's made for us. How are you already measuring the very diverse, and they are very diverse, projects which have been done for tendering Basildon and Colchester in terms of the pilot, and obviously that's now grown, Castle Point, etc. But how are you measuring those, because that could be a starting point for measuring rather than coming to us and asking us questions that you've already got the answers to.
Thank you. I'm going to bring Sarah through. She's been very patient. Sarah?
Yeah, it was just a question, Adrian. Are you connected into the affordable food work and the food strategy manager?
Yes. So that's a good prompt, Sarah. Thank you. So my team of people and Jason's team of people are looking at operationally where they can best join up. The affordable food is a fantastic one. So again, there's great work that Jason has been done using national government funding to look at the affordable food programme and if you like, rippling out the effect of physical activity to include a whole load of other things like affordable food in a place. So what we're not doing is saying, well, let's have a separate approach. We're basically piggybacking on the good work.
So are you in connection with Anna, the new food strategy manager?
Quite possibly. I don't know all the
If you're
names.
not, no, if you're not, then I can put you
My
in
hand lady, Emily Fallon, certainly. But if
Emily's definitely connected to Anna, definitely. I've seen her in her induction plan. But yeah, it was just to say that piece of work, one of the things that's very high on that agenda is how do we support people who have food poverty issues to make healthy choices. So I wanted to make sure that connection was there.
And that's a really important point about, one of the things which we, I think, don't understand well enough is we assume that everybody has the same level of agency to make healthy choices about food. That is fundamentally not the case.
Yeah, absolutely is.
There's a basic fairness and kind of moral and ethical issue around creating conditions where people have half a chance to eat healthily.
There's an education piece there as well around people not necessarily knowing how to use vegetables and how to cook from scratch. A very strong education piece.
Absolutely, one understands that. There are ultimately two TV programmes which illustrate it. I want to bring others in. Ian, you were whispering to me. Was there another brief point you wanted to make?
No, it was only just the point around making sure we get the understanding of what that asks and about how we make sure we can actually disseminate that.
So can I just come back?
Can I bring some others in, Adrian? Otherwise, nobody will get to the word. I mean, to me, the ultimate incentive here is the ability to demonstrate that through some of this work we avoid hospitalisation. And I don't know what evidence you've got of that. Ian Tompkins?
Yeah, two quick points. One, I think, is not to leave out, I'm sure you're not, Adrian, the importance, bearing in mind that when you get to my age, it's too late, right?
No, it's not.
Generally, it's younger. It's what are the kids being given, not nourishing our future in early years settings. That's the critical period. Yeah. And as the early years settings, people say, they've often been looked at as the Cinderella of this kind of agenda. And then what are we giving students in schools as well? I don't know when, if anybody would like to come to Harlow and have a school dinner or school meal, please get in touch with me and I'll arrange it. But it's something just to see what they're doing and actually understand what the menus are from that point of view is so important.
Yes, I would point you towards the Nourishing Our Future stuff that we did in with the conference earlier in the year, and Emily will be very happy. She's now been brought on to one of the parliamentary committees on this piece. Laura?
Thank you. It's just really, as you know, I report into Ian as well, so I'm more than happy to just work out exactly what you want Ian to send out. I absolutely recognise how complex this is, and I think the one thing I would say is that we have to be very careful about recognising what's in the gift of this board, recognising that obesity is such a complex challenge, and actually it's the social norm now. When we have nearly 70% of adults in Essex overweight, I think we have to be realistic around exactly what we're going to be asking partners to do that's within their gift and sphere of influence. But I'm more than happy to support you and then work with Ian to get that out for you.
Thank you. Thank you, Laura. Anybody else? No. Can I invite both of you to respond, please?
So just on the point around exactly what the ask is, and it's allied to what Laura has said, So there will absolutely be a very specific ask. So we are at the moment looking at, we've mapped who is doing what currently in Essex. And what we are trying to get to a point is, if you're this person in this organisation, based on the evidence, the collective expert opinion that you've got, this is the best thing you can do for greatest impact. Greatest impact is defined as the greatest benefit for the largest number of people over the longest period of time. I'm not interested in 3-month weight management programmes where people lose weight for a certain period of time, then the weight goes back on. That's not good use of funds. So we need to look at doing something which is different. So that's an example of a specific. So from a district council perspective, we have, for example, tasked all our public health practitioners, which we public health jointly fund with the districts, and said that the highest impact things you can do are to focus on policy and planning work. So there's a question there around, is everybody doing that? How many of the 12 districts are doing that? If it's not being done, what's the reason for that? But I think Laura's point around, what is within our gift to influence, obesity is so unbelievably complex. Stage 1 of evaluation is just really getting a better sense about what our collective influence can be. That in turn defines what the ask is. There's a real danger in being too premature with a really specific ask, or we don't have enough of an understanding of the system. So I think, today is not, I'm not coming here saying with a vague ask, I'm asking you to support the importance of evaluation, and just to say to your people, evaluation is desperately important. On the point of it's not just a health and wellbeing board, absolutely right. I'm having discussions with economic growth and sustainable growth people at the moment. Their input, they have a role to play in healthy weight. That's absolutely critical. So this is one of a number of groups that we'll be talking to. Thank you.
I would just, Adrian, I know how utterly committed you are, and you're doing some great work. Thank you very much for all that you're doing. It can just feel as if you're coming from a piece, if I may just say, we know best. And what was at the heart of the work that Active Essex did with Jason and Parrot was transferring ownership. So I don't think any of us will doubt evaluation. I think I'm just invite you to, how do you get each part of the system, whatever that means, to own this piece? I mean, Jason, that was a key part of all that went on with the delivery pilot, wasn't it?
Indeed, and I suppose one of the points, just to finish off, I suppose your question was what am I taking away? I suppose I'm just taking away that the continued need to share some of that learning that Ian and others have described, and particularly your point, John, actually, is just the amount of the locally trusted organisations in our communities, in our place, that can play such a critical role in supporting to land this. So we move away from the doing to, which I think is exactly what you're describing, and we talk about asset-based community development, where assets are not just physical assets, but people in our communities, and how do we utilise those people in our communities to really ensure that we're not doing two but working with and co-designing. I think the final point I'll take away is the young people piece actually in this room, actually really clearly actually how we're thinking about, and I just reflect on the fact that last year alone we saw 30,000 young people come through the Essex Activate Hard and Food programme. So actually what more can we do to ensure that we're getting some of those messages over, and particularly the point around education of parents. We've got an audience here, are we absolutely squeezing the lemon, as I like to say, as much as we can to ensure we can educate some of those parents when they come to pick up their children, and some of those key messages, and we know the government have just confirmed further funding for that for a further 3 years. So again, there's a real codependency between Adrian's work and our work about how I can use that audience to support and drive some of those messages, John. So that's certainly something we're taking away.
You're both stimulating the brain tremendously, thank you. I mean, I just observe life habits start very young. The mental health report to which I alluded earlier in this meeting reports how the average age of mental health crisis is getting younger and younger. One might wonder what the proven connection is between poor weight or obesity and that mental health crisis. So we are all, I think you're getting all acceptance, ready acceptance. We need to evaluate. We need to make sure we're understanding all the best practice that's going on everywhere, so that people can, Adrian, in a way, select from the menu of best practice as to what particular priorities prevail in their place. Okay. So thank you very much for all you're doing. Sarah, did you want a final word?
No, that's fine, thank you. I think we'll come back to you with what we want to engage you on and get your help and support.
Thank you. It's been a stimulating meeting. We're coming now to the Integrated Care Board updates, and I'll pass over to the chairs. Before I do so, when the ICB changes were first announced, Michael Thorne indicated that he would be stepping back from activity in the health sector in Essex. I'm not going to use the word retiring because Michael Thorne will never retire from life. I want to put on the minutes and the record the vote of thanks that the population of Essex owe to Michael for his activities over the last 2 decades. I had the privilege of serving with him as the governor at Anglia Ruskin University when he was Vice-Chancellor. And the words I used on my retirement, Mike, is that you took that university from adolescence to maturity, both increasing its capacity and its expertise around many fields absolutely vital to the people of Essex. And above all, of course, created the vision and started the delivery of the medical school, which you always said would be a medical school to provide medical training for local people to bring doctors back into the local system. And we see the benefit of that very clearly. As chair of the Mid and South Essex Integrated Care Board, you have not had your share of challenges to seek. We've tried to make sure you are well equipped with those. You have fought your corner, and you and I have had healthy disagreements on occasion, but never have I doubted your integrity and your absolute commitment to do what you believed was right. So on behalf of the people of Essex, if I may be so bold, I'm going to thank you, Mike, for all that you've done. And do you want to say, you can say something if you want. You really want.
Can't change the habit of a lifetime, John, but just to say thank you. I mean, what you do is in partnership with others and through the hard work of everybody involved and the commitment of everybody involved, and you're just part of that, and you know, it's a privilege to be part of it. And, you know, rest assured, I haven't yet called for my metaphorical pipe and slippers, but thank you, John, very much. Everybody, thank you.
And secondly, therefore, we welcome Paul Baxter, who we know so well, of course, who is now the chair-elect of the new Greater Essex Integrated Care Board as it comes into legal being on the 1st of April, but I know huge amounts of work. So, gentlemen, can I pass over to you to give an update to the board?
So I'm going to start, and then Tom's going to pick up on some of the things I think you were keen that we did talk a little bit about, which was the league tables. As you've just said, we've had confirmation from a written parliamentary statement that the new ICBs, including Essex, will be established from the 1st of April next year. I think it's just worth stressing that this is not a merger, it's a new organisation that will be established from that date. And as you've said, the chair designates have now been announced, and we're awaiting the announcements of the CEOs. And also, once that's done, it will be followed by announcements of the newly appointed executive directors for the new footprints. We're busy standing up the governance for Essex-wide decision-making and oversight, and also managing the transition, really to make sure that we are able to act on behalf of the 3 legacy ICBs as part of this and begin to create the notion of an ICB for Essex. There's much to do to safely close the 3 ICBs that are relevant to this Health and Wellbeing Board and to successfully open the new one, not least managing the anxieties and worries of our staff who still await clarification as to what the process will be around reducing the numbers of staff that will be employed by ICBs going forward. One of the major tasks over the next few months will be the first round of the new format for planning, some of which has already been started in some forms over the last year. That involves obviously re-articulating for the whole of Essex our commissioning intentions and beginning to develop the first of a series of iterations of multi-year plan. And that's very much, I think, intended to build on the healthies, which are the sort of frame that South Essex has been using, and which very much echo sort of approaches of the other two systems. Also drawing very much on the strengths, as we've discussed in this board on a number of occasions, of the different components that are coming together, particularly, I think, in terms of integrated neighbourhood teams, neighbourhood health, and so on. Just make sure we're learning and transferring that learning into the new organisation. And of course, all of this rightly needs to be done in partnership with our local government partners and with our wider public sector partners, and of course with the voluntary and community sectors as well. So it's no small task, and all I would just end by saying is a big thank you to Mike as well. Really echo your comments, Chair. It's been a pleasure working with Mike, and I'm sure we will not completely lose him from the scene going forward.
Thank you. Others from the ICB leadership?
Maybe if I just say a few words around sort of some of the more immediate issues, I guess, within Essex. So I'm sure everybody within the board will have seen the publication of the league tables or the outcome of the National Oversight Framework Assessments in NHS speak. But clearly that sets out quite clearly the need for improvement within the provision of NHS services across Essex. You know, if you take the league tables as read, we don't have any organisations which are up there in terms of the top echelons of the way that the NHS and the DHSC are now assessing NHS performance. And so I think one of the key priorities for the new ICB is to firstly obviously work and support those providers around what are the steps that are going to be required to improve performance, but secondly also for us to understand what is the potential changes we're going to need to make in the commissioning of services across Essex, which will underpin better outcomes for patients, better sustainability of service for taxpayers, and better experience for the people who work within those services. And so I think we have to do that across Essex, and that'll be something we want to work with partners on over the course of the coming months as we do the planning work that Paul sets out. I think in more positive news, and Laura and Tony might want to say a few words on this, both North Essex and West Essex were successful in being the first wave on the neighbourhood health pilot sites, and so I think that's really exciting opportunity for us to see Essex in the vanguard in terms of the building of the new neighbourhood health service set out within the 10-year plan, and also to help develop the learning which will support, I think, the rollout of that more broadly across all parts of Essex in due course. But I don't know, Laura, Tony, if there's anything you just want to say on that, because it's obviously you've done an awful lot of fantastic work, both of you, to get that status, and so there's a lot more work to do.
Laura, I'll bring you this out. I mean, thank you. What the feedback one gets actually is, so the league tables are what the league tables are, and they're sometimes harder for people to grasp, if you see what I mean. We must remember, of course, it's not just Mid and South Essex that have got the challenging rating. We've got Princess Alexandra as well. It's then the supplementary pieces that are coming out. So this morning it's children and young people. The maternity inquiry that Wed Streeting has announced, in which Mid and South will be one of the 14 as it featured. And it's my concern all the time is to ensure that we retain the confidence of the people of Essex in terms of all the different services we provide. I'm assuming that there are PR activities which go beyond the inner circle, if you see what I mean, the usual crowd coming down the line.
Yes, and so just because Mid and South have not been included in the maternity investigation, and they're not one of the. I know there was rumours that they were going to be one of those organisations, but in the final list that was published, they're not. I think that's the need, as I've set out, John, for us to support those organisations to really clearly articulate and publish the improvement plans that they got in place in order to rectify performance, because that, I think, the demonstration of that and the demonstration of the progress against those plans are the things which I think will ultimately help build and restore public confidence where that's lacking at the moment. And alongside that is there may be certain areas where, due to the nature of the service, it is currently unsustainable, that we're going to need to, the ACB is going to need to take commissioning action in terms of the reconfiguration or changes to that service, and so we can, we can see improvements in those areas which are beyond the local control of an individual provider.
Laura, I'll bring you in to talk about, again, the feedback I'm receiving from others is that's fine for them. So what does that mean for the poor old residents of Mid and South Essex who aren't part of the first wave? So can you help us understand what the first wave is and why people who aren't on it won't feel too injured?
I'll actually ask Tony to come in for West Essex, because West Essex got it as well, if that's okay, Chair.
Yeah, so we're obviously really pleased that we've been successful in West Essex in getting on the first wave, and the same for North East Essex. That's 2 applications for Essex out of 141. So I think that's lots for us across Essex to benefit from both of West Essex and North East Essex being able to participate in. Is how do we network that learning so we can benefit within the Mid and South Essex system. We're really pleased that we got through. We do believe with their feedback, we had a strong application. It recognises the work that I think we shared probably at the last Health and Wellbeing Board around, our maturity of our integrated neighbourhood teams, our care close to home model. So I think it was good to get that recognition, but also get the recognition that it is not just about what we do in the community, it is about our acutes, and it's our acute hospitals being part of the community, but also what we're able to achieve through neighbourhood health is about how it supports our performance that we are seeing in our hospitals, so making sure we are delivering that left shift into the community through how we develop our neighbourhoods. Our focus, no surprise for West Essex, is focusing on Harlow, and it's focusing on those people with long-term conditions, and again, it builds on the work that we shared previously around Frouty. And picking up I'm hearing different things now because we're part of the neighbourhood programme, picking up on some of the conversations this morning around Connect for Work, the Active Essex stuff. How do we make sure that we can use the opportunities through our neighbourhood health programme to really drive some of the pace of change that we need that's broader than health? So I think, again, there's an opportunity for us through our neighbourhood health programmes of doing that for the benefit of Essex, not just for these particular programmes. So we're absolutely delighted to be part of it. We're already working on it without actually being part of it or attending the first national event. But really excited and got real system buy-in from the patch.
Yeah, and for North East Essex, we had really good feedback. Ours came back around leadership and partnership in trying to address health inequalities, which for, of course, our population in North East Essex is so vitally important. We're, as Tony said, really keen to understand how West and North East Essex can come together and then share the learning. The one thing I would say is that it's very early days to know the exact detail of what we've got to do, but we'll be sharing that as we progress. And I think also just recognising, I'm sure Will won't mind me saying, but Suffolk and North East Essex, we believe, was the only ICB in the country to get all 3 places. So we've got full coverage in Suffolk and North East Essex. And I think there's something about how we continue to share learning with partners as part of that wider regional network, which I think is going to be really important so we can see greater benefit to everybody.
Thank you, Tony. Laura. Ian was bursting to get in.
I am. Just to say, it's a reference Tom made, and also about talking, but this is a public sector. It's not just about health. Yeah. Pilot and what can it achieve? Because we will miss an opportunity if we do think of it as a health outcome. It's just acute, it's just this. Actually, it's not. To make a difference, it's got to be the public sector. And we were very involved as a local authority, Laura testified, and I was just trying to get the quote back up, which of the feedback we got from government about it, and it was about the whole public sector, not just about health. So please, when we do look at this, it is a whole public sector, and it will only be successful if it's treated as such. And incidentally, so was Essex County Council was very much a part of that and part of our conversations in it going in. And we were happy to. Obviously, Laura did a brilliant job of leading for us on our ones, but we were very, very pleased to have your involvement in that.
The challenge is to convince the people not to be true.
Yeah.
That it's all public sector and it's under the sponsorship of health.
And I think that for the Alliance, which we have in North East Essex, I'm going to kind of just use that for a moment as an example, is about how we grow that and kind of change, and we make sure we grow that for the whole of Essex with the new ICB and the approach. I think that our partners across the North East have got that, and I think that, to be honest, that's why the 3 were successful.
Okay. Any other points?
Sarah.
John, sorry, is it worth just mentioning the test, learn and grow, because it is relevant to the neighbourhoods? So there was a national government programme around, there is test, learn and grow, where we had to put in some submissions about some of the things we might want to work faster on, and it's about transformation, a different way of working with national government, and they put in a team of people that help us to do what we need to do quicker and focus on innovation. So we were successful on 2 areas that we put forward. One was work and health, and getting people with a long-term condition or a health issue, so disability as well, to getting those into work as a priority group, which will link into what Jonathan said earlier. But the other one we were successful on is neighbourhood working, and the neighbourhood working is in the context of focusing on coastal communities, and I believe, Moira, you were involved in that one, I think, weren't you? So we'll need to think about how we maximise that opportunity, not duplicate it, and make sure that the whole of Essex has the opportunity to benefit where we can, so that it comes together and we get the most out of them.
Thank you. And initiative-itis comes to mind, doesn't it, really? Sorry, I shouldn't have used that word, initiative-itis. I was at a board meeting yesterday where the Chief of Executive used the word behaviouralisation and complexisation. I just written it with AI. Are there any other points? But we do need that link up, and it actually comes back exactly, Sarah, as you said, to what we were saying with Jonathan and Kevin. I am mindful that the participation is shrinking, and I do need to do 1 or 2 things quickly. Sarah? Laura, sorry, Laura.
Sorry, it was just one other thing, is that there will this board will have oversight of the neighbourhood health plan. So sort of understanding how the 2 pilot sites working with Essex ICB can really start to feed into that. And I've had a conversation with Sarah, because I think that may well be something that the expectation from the national team is that comes forward quite quickly. So I think this board needs to know that it will have oversight of that going forwards, and I think that's really important, actually.
Does it begin to feel very congested?
It does.
Tony, Laura, thanks. I didn't thank Tony for earlier piece. Anybody else? So we will work very closely. And I do want to just say to everybody on the ICB table, thank you so much for the very, very positive hand of partnership that's as evident as it's ever been, probably more evident than it's ever been. So thank you all for that. I would just say local government reform, reorganisation. The argument was on. The papers will go on. There will be a business case submitted for 3, 1 for 4, 1 for 1, maybe 2 for 4, 1 for 5. Let's get past that. And when we meet on the 24th, we start, for my way of doing, really beginning to work together, regardless of on what side of it, largely political argument in many ways, to create the best health and care system, big S, small s, for the people of Essex in the coming months. We cannot wait till we know what the government decide about the number of unitaries to start really getting our hands right about how to make this work to best effect. Everybody should have had an invitation to the event on the 24th of September. If you have not, is Emma still here?
Yes, John.
Yeah. Speak to Emma now, please, because we do have about a handful of places still to allocate. Otherwise, is there any other business?
Can I just extend on what you were saying? Because we talked about LGR. A number of the references today have been about mayoral responsibility. And of course, the elected mayor for Essex comes in 2026. And so I think we perhaps need to also pick up next week about how we approach that preparation.
Yes, very much next week is not the solution, it's the start of the piece. Exactly. I mean, I would say on the mayoralty, the papers are going before Parliament. The election will definitely happen in May 2026. The mayor will initially have the support of a mayoral authority with representatives from the 3 upper tier councils in the short term until the shadow unitaries are elected. Their legal responsibilities in the first instance are limited to those in the white paper, which is to do with skills, to do with transport and strategic planning and economic growth. It's really quite limited, there's not so much in the space. However, they do have an interest in health, and it will be in the interest of every resident of Essex that whoever that we work with the new mayor to see how that can be achieved and allow cross-county conversations and actions where they are.
Helpful, which I can circulate to everybody, which is issued by NHTLG. It's on one page and gives the areas of policy, the subnational strategies, and where the mayor is responsible for them.
Could you attach it to the minutes?
Yeah.
And what does happen is after the mayor's got their feet under the table for a bit, they can start acquiring more responsibilities. So you have an emerging authority and a mature authority.
It also highlights the powers they have.
Any other business? Any other business?
Just for information, I would stress that in the white paper it says that the mayor will have a public health duty. It is stronger.
Yeah, I was admitting. Yes, fine. As well as the interest in health.
Yes.
Fine, thank you.
There's a couple of other items. There's a forward plan, and Nathan was just going to say something on that if that's
Nathan.
helpful.
Yep. So you've all got a copy of the current working forward plan. If there are any requests for any other items, you can Secretariat by Friday the 3rd of October. We've had one through from Clyde already, which we'll be bringing to the next meeting, the next agenda setting meeting. But if there's any other items, if you can email the Secretariat by the 3rd of October, if possible, please.
And there was certainly one emerging this morning, wasn't there, Nathan? Do please, this is your meeting, not ours, so do help us frame the agenda, please. Yes, your next one, Will?
Dates of next meeting, 19th of November. It says at 9:30, but is it going to be 9:45?
Yes, we moved it to 9:45 as a standard.
And then it's urgent business.
And then just on dates for 2026, have we circulated? It's the plan to keep with the 3rd Wednesday of every odd month, as we have done. We will check that for clashes with Easter. We will also look at, I think we tend to go into January to the very end of the month, so as officers aren't writing papers over Christmas. So we'll circulate those as well in a minute. Yes, any other urgent business? I have not been notified of any. Do you know of any, Bill?
Other than the need for a cup of coffee now.
And on which note, I understand how much trouble I will be in if I find any further discussions.